introduction, without wasting much time, I want to invite Dr. B.K. Singh, our zonal member RSSDI, to the dais to chair a debate along with respected Dr. Hari Prasad sir, and Dr. Atul is not here because he has been to Janakpur. I don't think he will be able to return for the talk. So Dr. B.K. Singh and Dr. Hari Prasad sir, kindly occupy the dais and please introduce the topic and the speakers. It is a very interesting one, diabetes coronary risk factor, and they will be calling our erudite speakers, young but erudite speakers, to the dais to have this debate. Over to you, Dr. B.K. Singh.
Thank you, sir. First of all, good evening to all of you, and really it is my pleasure to come to the Sitamarhi, the land of Janki. And one madam has said the whole world is praise to the female, our female person, the Shree, then Shree power. So with this word, I want to invite the first, this is a debate. That is, a diabetes is a coronary heart risk equivalent. Either it is yes or no. You all know that a diabetes is not only a disease of hyperglycemia, but it is a release of vasculitis, inflammation. And so I invite first speaker, Dr. Purushottam Kumar. May I invite Purushottam Kumar? To introduce Purushottam Kumar, I request my co-chairperson, Dr. Hari Prasad, to say a few words.
Respected National President RSSDI, Professor Dr. ANUJ MAHESHWARI, and Chairperson Bihar RSSDI, and other delegates, and my friends. First join a talk, diabetes coronary heart disease equivalent risk, Dr. Purushottam Kumar, and everybody knows him, and he is a interventional cardiologist, and he will talk on subject जो है coronary artery disease, diabetes coronary risk equivalent.
In favor of the coronary artery, diabetes is equivalent to coronary artery. Dr. Purushottam, please.
Hello, good evening. Welcome all to this conference organized by RSDDI, and I extend my warm welcomes to all dignitaries. So I have been imparted with the topic of diabetes, and is it a coronary vascular risk equivalent? So I am going to speak for the topic. So with changing time, the lifestyle management, the management of diabetes has changed, but what has not changed is the incidence of diabetes. We have kept on reading that diabetes has been very prevalent among every part of the country, every part of the world, and it is still becoming a pandemic. So the deaths which diabetes cause, is it because of the cardiovascular risk? Are we going towards that pandemic, that post-COVID also, the NODACs, that near-onset diabetic prevalence has increased, and the cardiovascular risk involved with it has also increased? Or is it just a generalized simplification that a diabetes patient is having a cardiovascular risk? So when we go through the history, the diabetes is having many classifications. It is like touching the parts of the same animal, and it is actually glucose intolerance, then pre-diabetes, and insulin resistance, and then hyperglycemia, which causes its multiple effects on the cell bodies. So on the cardiovascular implications, the cardiovascular complications of type 2 diabetes is that it increases coronary heart disease deaths by 2 to 4 folds. 65% of the death in diabetes are due to cardiovascular diseases. The stroke risk increases by 2 to 4 folds, and heart failure increases by 2 to 5 folds. Now the mechanism which causes diabetes leading to this pandemic episode of cardiovascular diseases is, it is because of the insulin resistance and hyperglycemia. So when you go through the microscopy of a cell membrane, the cell membrane is made up of lipids and proteins. So for long duration, when you are exposed to hyperglycemic events, that cell develops memory cells. That memory cells leads to development of shift bodies, which is known as Browning or Maillard effect. And this shift bodies on redox oxygen potentials or low oxygen redox potentials exposure gets converted into Amadori bodies. Now what are these shift bases and Amadori bodies? So this leads to alteration in the cell membrane proteins, and there is attachment of advanced glycation end products. Advanced glycation end products will lead to receptor mediated changes and non-receptor mediated changes. The receptor mediated changes will promote the inflammation. There will be secretion of cytokines such as tissue necrotic factor alpha, interleukins. There will be chemotactic stimulations for monocyte and macrophages. There will be cellular proliferation of platelet derived growth factor, and then there will be endothelial dysfunction. Endothelial dysfunction, basically when you talk about the endothelium, normal endothelium will be releasing nitric oxide. There will be cell permeability, there will be vascular growth, there will be patients in which nitric oxide release will lead to dilatation of the arteries. So that mechanism is altered, and this endothelial dysfunction leads to increased permeability of EC monolayers, that is endothelial growth factors, increase procoagulant activity is there, increase expression of adhesion molecules are there. Then non-receptor mediated mechanisms, it will lead to vascular remodeling, which is divided into three parts of extracellular matrix, functional alteration of regulatory proteins, and lipoprotein modifications. So glycosylated LDL production will be more. There will be reduced LDL recognition by cellular LDL receptors. We have read about PCSK9 inhibitors, proprotein kinase, subtelsin kinase converters, in which the LDL receptors, when you inject a patient with PCSK9, the LDL receptors bind to LDL cholesterol more and it is removed. So that mechanism by advanced glycation end products is hampered, and the LDL cholesterol is increased in the body. So when you go through this chart, it highlights it that when there is more monocyte macrophage accumulation, the defense mechanism reduces, there is increased pathogen burden, the inflammation increases, there is increased interleukin 6 CRP, there is hyperglycemia, advanced glycation end products, and increased oxidative stress is there. Insulin resistance grows, which leads to hypertension, endothelial dysfunction. Dyslipidemia is more with increasing LDL, increased triglycerides and reduced HDL, and thrombosis becomes more. So this leads to subclinical atherosclerosis, and the disease progress towards ASCVD. Now when you move towards the diabetes spectrum of cardiovascular disease, you have basically microvascular changes and macrovascular changes. Macrovascular changes have coronary heart disease, heart failure, peripheral artery disease, and stroke. The prevalence of coronary heart disease is 14 to 21%, and microvascular changes, retinopathy, neuropathy, and nephropathy is there. So there have been many trials which suggest that control of hyperglycemia can lead to changes in macrovascular or microvascular changes. There have been trials like ACCORD, ADVANCE, VADT, but they have failed to show that intensive glucose glycemic control will lead to reduction in macrovascular complications. So ACCORD and ADVANCE have been a very large scale trials in which patients have been randomly assigned with diabetes, and intensive therapy has been given, but the primary outcome did not show any reduction in macrovascular complications. Then there is UKPDS findings also, in which the risk reduction with 1% decline in annual mean HbA1c did not reduce the rate of MI or stroke substantially. So American Heart Association has recently identified diabetes as a new risk factor for cardiovascular mortality. Earlier it was physical inactivity, blood cholesterol, smoking, blood pressure, high blood pressure, but diabetes has been incorporated as a independent risk factor for cardiovascular diseases. Now this has been an original research trial, which original research paper which has been published in 2019, which highlights that diabetes mellitus related all cause and cardiovascular mortality in a national cohort of adults, and they had taken around 9,63,648 adults in the US Veterans Affairs healthcare system from 2002 to 2014, and they have followed them up for a mean period of 8 years. Now, the conclusion was diabetes mellitus remains significantly associated with all-cause and CVD mortality, although diabetes mellitus related excess mortality is lower in the contemporary area than previous, and they have observed a gradient of mortality risk with increasing HbA1c with more than 6 to 6.9%. So, the hyperglycemia, increasing hyperglycemia leads to increase in all-cause mortality in diabetes, that has been confirmed. But other trials which have given a base control of hyperglycemia will reduce all-cause mortality, that has not been proved. Now this has been a full research paper in ESC preventive cardiology, which says diabetes is a cardiovascular risk factor, and it also highlights that adults with diabetes have 2 to 4 times increased cardiovascular risk compared with adults without diabetes, and the risk rises with worsening glycemic control. Now, what is the spectrum of patients who have diabetes and have coronary events? They can have silent ischemia, they can have multivessel coronary artery disease, they can have restenosis of their stents, they can present with diabetic ketosis, and most of the patient lands into bypass surgery. So, what is the general cycle in which patients have? That physical inactivity leads to increased oxidative stress. The weight gain is there, then the patient will have endothelial dysfunction of hypertension, include blood glucose, activation of the RAS system, diabetic nephropathy, hypercoagulability, then the patient will land into dyslipidemia, and then inflammation, autoimmunity, endothelial dysfunction will be there. This is my research in DNB, in which I have done a correlation between syntax score and clinical presentation in diabetic with ischemic heart disease. And this I have published in European Journal of Cardiovascular Medicines also, in which I had taken 101 diabetic patients and 99 patients were non-diabetic. I have compared their syntax score. Syntax score is a calculator which gives you idea about the patient's coronary artery disease severity. So syntax score in diabetic patients were much more higher than non-diabetic patients, and these patients were landing up for more bypass or multivessel PCI. Or these patients were having much more graded complications of restenosis or reinfarction than non-diabetics. So is diabetes mellitus a cardiovascular disease risk equivalent for fatal stroke in women? This is the data from the Women's Pooling Project, and the conclusion is that they have a fatal stroke risk similar to that of non-diabetics. This is a paper which has been recently published as a coronary artery disease risk factor. Just 2 minutes, sir. Diabetes mellitus quick takes. In this study, presence of diabetes was found to be a CVD risk equivalent in 1/5 of CVD free adults living with diabetes, and for patients with diabetes without prior CVD, there is a higher associated relative CVD risk among women. So the women who are having a protective effect of their gender, that is also lost in patients with diabetes. There have been many trials which have been published on net, right from the NCEP 83, which has established as patients having diabetes having already a MI as compared to patients of non-diabetes with a MI. And these are the latest guidelines which have been done by ESC, ADA, ACE, AHA, and US task forces, which can be readily read on the net. So we need a holistic approach in patients of diabetes to prevent the cardiovascular risk factors. Like we have to control the hypertension, diabetes, cigarette smoking has to be stopped, and then there have been many drugs also which have been taken into consideration. The newer drugs is GLP-1 receptor antagonist, and the trials which have shown reduced MACE.
Dr. Purushottam,
leader,
please
rewind and sustain.
conclude.
Thank you so much.
For against the motion, I invite Dr. Manas Thakur.
is DM
Dr.
Cardio.
Sorry, एक minute.
For those who don't know him, he is DM Cardio, and he will be speaking against the motion.
Good evening, everyone. Without wasting much time, I will just speak few words about the diabetes is not a coronary heart disease risk equivalent. So initially, like, what is the link between the diabetes and CV risk? Like, it has long been recognized as a significant risk factor, and early research suggested that diabetes convey the risk of coronary heart disease compared to the previous myocardial infarction, leading to the CHD risk equivalent. However, recent advancement in research and clinical understandings have challenged this assumption, prompting re-evaluation. So what is basically CHD risk equivalent? It is a condition where the individual risk of future CV events is considered to be as high as that of someone with a prior MI. So we have to primarily focus on mandating aggressive secondary prevention strategies. So coming to the genesis of concept, like the concept of diabetes as a CHD risk equivalent, a study was done in earlier 1998. It was suggested that a study compared CV event rates in diabetics without history of MI to non-diabetics with prior MI, and it suggested similar elevated risk. So it was established that it is the same CV prognosis as established CHD. So what were the critical limitations of early studies? The studies which were done earlier, that was a small sample size, older populations, poor glycemic control, lack of modern therapies, and limited ethnic presentations. So coming to the heterogeneous nature of diabetes, it is not a monolithic disease and highly heterogeneous conditions. It varies significantly and influenced by a multitude of factors like duration of diabetes, glycemic control, presence of complications, as well as age and gender. So coming to the duration of diabetes, length of the time is the main critical role in their CV risk. And there is a misconception also that diabetic patients face an immediate uniformly high risk equivalent to CV risk. So coming as these all points are taken with different studies, like patients with short duration diabetes, especially those recently diagnosed and with well controlled glucose levels, generally exhibit a lower CHD risk, and with long standing diabetes, that is typically more than 10, evidence of metabolic dysfunctions are there, there is a significant elevated risk. So the risk is not equal at the point of diagnosis, but rather accrues over time. So coming to the interplay of additional factors, definitely there are additional risk factors that is called risk multipliers, which which does not automatically equate to the CHD risk equivalent status, like hypertension, dyslipidemia, smoking, obesity. So diabetes alone does not equate to CHD equivalent, as there are risk multipliers. One meta-analysis was suggested and was done, and it suggested that diabetic patients without a prior MI generally have a lower risk of future CHD events compared to non-diabetics, which are already have MI. So what were the spectrum of risk in these patients? Like diabetes exhibit wide variability, reflecting the heterogeneity of the disease and influence of other risk factors. Many diabetics remain low risk, as because if they are well managed conditions and without extensive comorbidities, may remain at low CV risk. And if there is a risk, if we consider as a CHD risk equivalent, overestimation of individual risk potentially results in unnecessary aggressive treatments and patient anxiety. So we should focus on individualized risk stratification approach, considering duration, control, and comorbidities. So coming to the one imaging evidence also that gets in score, that CSC scores, it also suggests that many individuals with diabetes present with 0 or low CSC score, suggesting a lower degree of subclinical atherosclerosis. So this finding is significant because it indicates in some cases the atherosclerotic burden in diabetes is not directly comparable to the established CHD. So what were the critical role of glycemic control? If the patient is well controlled diabetic, it has reduced CV risk. If has poor glycemic control, suboptimal glycemic control directly correlates with the marked increase in CV risk. So equivalence overlooks the nuisance. So treating diabetes as a CHD equivalent often fails to account for this crucial difference in glycemic control status, potentially leading to inappropriate risk assessment. So concentric, as already discussed in this previous topic, like female diabetics, for instance, often exhibit lower absolute risk, as it was previously. So disparity suggests that one size fits all approach to risk assessment may lead to over treatment or under treatment in specific patient populations. So another one slide is just to show that type 1 and type 2 distinct risk trajectories. It varies significantly in both types of diabetes. Type 1 risk is often heavily dependent on disease duration, as with younger patients frequently presenting with lower immediate risk. So as we know already, there is advantage in diabetic management. The slide showing statins, antihypertensive, SGLT2 inhibitors, integrated therapy, and GLP receptor agonist. So what are the evolving risk prediction models? There are few scores in prediction of scores like ACVD, score to QRisk. These tools no longer classify diabetes as a direct CHD equivalent, but rather incorporate it as a powerful risk enhancers. One more, like guidelines perspectives, no longer it is said that it is a no longer CHD equivalent, and it has already moved away from the labeling it like diabetes as a CHD equivalent, and individualized assessment to be done. That is, strong emphasis should be given on individualized risk assessment, and there should be focus on evaluating total CV risk. So diabetes as a risk assessment, this is a takeaway slide, like the tailored approach ensures appropriate preventive strategies, optimizing patient outcomes without undue overtreatment. So reframing diabetes and CV risk, the slide is like if the diabetes is heterogeneous, clinical presentation and underlying pathophysiology vary significantly, individual risk varies as it is not, the risk is not uniform in all individuals, and there should be modern evidence disappears. And lastly, individual personalized stratification is crucial. And so according to me and according to the studies, all diabetics are a high risk. So should not, while diabetes is a significant risk factor, but it should not be considered as equivalent, and the one size fits all approach, aggressive therapy is not supported. And there is like we should use individually, like use risk calculators, targeted therapy, avoid blanket labeling and prevent over treatment. And the future of CV risk assessment in diabetes, like diabetes remains a critical CHD risk factor, but it is not a universal coronary heart disease risk equivalent. So individualized CV risk assessment is a cornerstone of effective management, leading to better patient outcomes and optimized resource allocation. Thank you.
Thank you, Manas, for being just not only in time, but also before time. So excellent presentation, Manas. Now I invite Purushottam Kumar for rebuttal, and please stick to the 5 minutes time. You can have a seat, Manas, here.
Diabetes is still taken as a coronary vascular risk equivalent because post-COVID there has been a term coined, that is NODAX, neuro onset diabetes after COVID. The prevalence of diabetes has increased. Diabetes is already known to cause endothelial dysfunction. It is one disease which affects your head to toe, and endothelial dysfunction associated with increased thrombogenicity of post-COVID era. And the environmental factors, like we have taken into consideration PM 2.5 and PM 10, that is also affecting your endothelial activities. So diabetes with increasing age and passing time is considered to be a CV risk equivalent. There have been trials in the past like Ascend Aspri for primary prevention with aspirin, which have shown contradictory factors, like with patients having increased ASCVD risk calculator, you can go with aspirin or antiplatelets. But still in our clinical practice, we have seen most of the patients who are suffering with diabetes have coronary artery disease events much more than population who are non-diabetic. And with post-COVID era, the propensity of CAD has also increased whether or not they are diabetics. And if they are diabetics, then multivessel disease, I have seen in my own clinical practice with a lot of coronary angiographies and plasties that more number of patients with diabetes are having multivascular disease. They can be silent for a very long period of time until the plaque ruptures. And the upcoming trials or the upcoming studies have also shown that we have, like Hafner et al. Has suggested that it is equivalent to a MI in non-diabetics. But recently with advent of GLP and other drugs, it has been challenged that we have to not consider every patient of diabetic as a CV risk equivalent, and we have to individualize the treatment. But still with growing time, we have seen that diabetics have to be given primary prevention with statins or antiplatelets depending on the ASCVD risk, and hence I conclude that it is a CV risk equivalent. Thank you.
No, first of all, I want that have a rebuttal from the Dr. Manas, please.
Yeah, I agree with sir. like diabetes can be considered, but still trials suggest like it's a risk enhancer, but we can't just directly put in the CVD equivalent. But ultimately we have to treat the patient, so according to we have to stratify the individual approach of the patients.
Now I ask the audience, how many are in favor of this Dr. Anuj Maheshwari, sir, please.
Debate was good, no doubt about that. I think the second debater tried his best to save the point, but what the evidence suggests and what the current situation is coming up. As earlier we were not looking for a separate segment for the people, those who are having the cardiovascular risk, and they should be started on the SGLT2 inhibitor or GLP-1 receptor analog. Biggest thing in favor of that diabetes is equivalent to the cardiovascular risk or coronary artery disease risk is that about 10 to 15 years before the diabetes sets in, we develop or patient develops endothelial dysfunction. Endothelial dysfunction is a trigger point for the development of atherosclerosis. Some people takes 10 years to reach to the maximum level, some people takes 5 years, some people takes 15 years. Roundabout it has come out that about 15 years it starts in the process. Then the people gets MI or even angina or coronary artery disease many a times before the diabetes is diagnosed or sets in, even in the pre-diabetes period. So even pre-diabetes period could be an equivalent to the coronary artery disease risk. So what we can tell about the diabetes. So if we can really say that and wish to say that diabetes is not the CAD equivalent, then probably we are undermining the risk of the diabetes which is causing to our patients, especially for the cardiovascular adverse outcome. So that I just want to say, whatever the debate, at the point of debate, it's okay, you put your point right, you defended well, but the message to the audience should go right.
Very nice talk from both the speakers, and I agree with Purushottam. This is just like equivalent. So most of death you combine with CKD and coronary artery disease. So almost 3/4 deaths are from there. So there is no doubt. Just I want to highlight, there is a way back in '99, Dr. Sadi quote that all diabetics do not have complications. They have some genetic marker, so they do have complications, but they will be difficult to identify who is going to have complications. And subsequently also there are many papers. Even in हम लोग क्लिनिक में भी देखते हैं कि बहुत सारा मरीज को 250 जब आता है 250 300 रहता है, but no complications. Even at the age of 70 there is no complications. So this is one point to be made. Everyone is not prone to have complications. There are some genetic marker and they are more prone to complications. And another point, the two trials the Purushottam showed, where did accord and advanced. The preventive measure started after 9 years of uncontrolled diabetes. So that just contrasts to Wikipedia's trial. That is from earliest stage. So that's why that though both trials failed, advance and accord. Thank you.
Yes, yes. Please, sir.
It's not a question, a submission and a comment that medicine is a place where a truth is a truth, a result, a conclusion is a conclusion, and just we have seen that a father has a different opinion than his son. He doesn't support his son. So that is a submission.
Excellent, sir. And any more question? And do you want to have a question?
Just I want to add, diabetes is a very complicated, multifactorial disease, and it enhances the incidence of ischemic heart disease. And to add to this thing, in the management portion also, I want to say that aspirin is needed when one CSD is done. But just as such, aspirin is not given to all diabetic patients, though it is mostly because of the risk of complications. So this point is debatable. Both are, the audience will decide who is the correct. Let us have a vote.
How many have favor of that this diabetes is equivalent to coronary artery disease? And how against? Only 2 or 3. So both are winner. Basically the point they want to convey, the Purushottam and Maras both have same. One is said that the coronary marker, coronary events, that is the atherosclerotic changes, which is not equivalent to this as in diabetes. But you all know that the disease is disease. It affects all the system of the body. So metabolic disease have beauty that it affects all the system. Basically, there is a genetic factor also important, and some genetic factors are preventive and some is aggravating factors also. So few genes are protective in nature and few genes are the aggravating in factor. That is another question. But for the time being, you all know diabetes is not just like a hyperglycemia, which I initially said. It is a metabolic disease having the inflammation, and the inflammation sets when there is a hyperglycemia, and endothelial dysfunction is present even before the diabetes is developed. So that is one point, that the atherosclerotic changes which causes the coronary artery event due to vulnerability of the plaques is more prone to develop in diabetic patient or early to develop. And the message is very clear from this point of view that diabetes, the patient once developed diabetes, the coronary artery disease is going to happen very early. So with this debate, I congratulate both the speakers.
One thing I want to add.
Yes sir, CV Prasad sir. वही सोच रहे थे कि आप चुप कैसे सर?
Some molecular biogenetics are having role. Just like PDX factor, MAFA is there, and the progenetics like neurogenin 3 and SOX6 inhibitors. These changes are also responsible for the endothelial dysfunction, and so it's related to genetic side also, as Dr. B.K. Singh was telling us. Some tests are there for endothelial dysfunction. Flowmetry is there. Then your one progenitor cells test is there. These cells and peripheral artery this test flow should be done to determine the health of the endothelium. That's why I wanted to say.
Thank you, sir. Excellent comment by that. One thing is very clear: if you are a diabetic or especially diabetologist or a physician or anything, surgeon or anything else, if diabetes is developed, you must consider two things. Once, Dr. Rssdi said the aspirin, which is one of the protective mechanism, and second is the statin. If you are having more than 40 years of the age, you must try this aspirin, and statin is the two factor which can decrease the incidence of coronary. I think both of you must be agree with me. So thank you very much for your patient hearing, and please give a big round of applause to both the speakers. अरे इतना हल्के से मत बजाइए सर, महावीर ठाकुर जी आपके बेटे बजाइए जोर से. Thank you.
Thank you for the wonderful session. Congratulations both the speakers and PK for wonderfully conducting the session. Now I request chairpersons to kindly honor our erudite speakers.
सीतामार की धरती पर माँ जानकी का
प्रकट स्थली.
ताली बजाइए भाई, ताली बजती रहनी चाहिए. ताली बजाने से दो फायदा है कि यहाँ पर खाटी 61 जो है एक्यूप्रेशर पॉइंट्स हैं जो आपका डिफरेंट सिस्टम को अच्छा करेगा, इसलिए ताली जोर से बजाइए। मैं नहीं कर रहा, लक्ष्मी जी ने कहा।
Now I request the speakers to kindly honor the chairpersons.
अनुज जी आइए। मैडम 31 पॉइंट्स है एक्यूप्रेशर के, इसलिए जरा जोर से बजाइए।
Now, the next session is the star of the best, one of the best program of our schedule, which is involving FOGSI to a great extent along with physicians. This important subject, hyperglycemia in pregnancy, which is detrimental to mother, fetus in the present tense and in the future tense also. To have a panel discussion on that, I invite Dr. Sudha Jha, Scientific Secretary of FOGSI. And panelist for this occasion will be Dr. Anju Singh, Madam, who is President FOGSI, Dr. Madhu Singh, Senior Gynecologist, Dr. D. Sameem, who has been appointed as the District Coordinator. He was District Coordinator of Rssdi previously also, but he was not in active mode. This time I trust and assure you that he is going to be in the most active mode. Dr. Anjana Prasad, Madam, Dr. Naveen Kumar, Assistant Professor, Darbhanga Medical College, and I have the privilege of being his unit chief. Dr. Pratima Anand, not only the most energetic member of FOGSI, but of entire IMS Sitamarhi. Dr. Lata Gupta, the Secretary of FOGSI, and Dr. Risika, our young gynecologist and daughter-in-law of Dr. Sunil Singh.
Thank you. Thank you, Rssdi, to giving me the FOGSI members a chance to talk on panel discussion for the diabetes in pregnancy. And Dr. Jha has just called all the panelists. In a very less time, I'm just introducing them. Dr. Anju Singh, ma'am, she is President of FOGSI. Dr. Madhu Singh, Dr. Anjana Prasad, ma'am, she is President of ISOPOP Sitamarhi. Dr. Madhu Singh, she is Secretary of ISOPOP Sitamarhi. Dr. Lata Gupta, ma'am, she is Secretary of FOGSI Sitamarhi. Dr. Pratima Anand, most active, most helpful FOGSI member. Dr. Rishika, the new gynecologist, most promising and academic. Dr. M. Sameem, introduced, and Dr. Naveen. So, hello, what are the current ADA recommendation for diagnosis of diabetes in pregnancy? Dr. Anju ma'am.
American Diabetic Association along with International Study Group of Diabetes in Pregnancy, they recommended in 2011, they came out with a guideline for the detection of diabetes in pregnancy. They recommended that blood sugar should be only tested in high-risk patients. High-risk patients means patients who are having family history of diabetes, who are obese, who are having history of fetal loss, macrosomia, hypertension in last pregnancy, SDL level low and hypertriglyceridemia, all these things. So they are not recommending universal testing of blood sugar. They came out with the level that if a patient's fasting blood sugar level is more than 126 and random sugar level is more than 200, glycosylated hemoglobin level is more than 6.5, then they should be diagnosed as a case of overdiagnosis, that is pre-gestational diabetes. But in our country, the scenario is different. We are having huge population and incidence of diabetes is very high in Southeast Asian country. So in India, we don't follow this recommendation. In India, universal screening is for blood sugar is done for all pregnant patients. For diagnosis of gestational diabetes mellitus, they recommended, American Diabetic Association, they recommend testing of gestational diabetes mellitus. They recommend all patients should be tested between 24 to 28 weeks gestation. And for this, the patient is asked to come fasting in the morning, and then fasting blood sugar is measured, and then after giving 75 gram of glucose, blood level is measured after 1 hour and 2 hours. If the fasting blood sugar level is more than 92, 1 hour level is more than 180, and 2 hour level is more than 153, if any one of the finding is abnormal, patient is diagnosed as a case of gestational diabetes mellitus. But in India, we don't follow this advice. We screen all patients in first trimester, and then again between 24 to 28 weeks, and again in 32 to 34 weeks. We test our patient thrice in her 9 months pregnancy.
Okay.
That's all.
In the interest of time, I will request all the panelists to be brief, precise, and just to the point. And thanks, Madam Anju Singh, for the wonderful explanation. Now, over to next question.
Dr. Anjana Prasad ma'am, what is one-step test? Because Indians are the ethnic group, so one-step test is recommended. And what is the one-step test, please?
Good evening to all. And this one-step test is actually a modification of the previously done 75 gram OGTT test. In this test, we have done this test very patient friendly and easy to do, and easy for the beneficiary also, and easy for the provider also. In this test, whenever the patient comes in first visit in ANC, we have to give them 75 gram of glucose dissolved in 300 ml of water, and ask them to come after 2 hours. And when after 2 hours she comes there, then we take her the capillary blood for testing. If the blood level is 120 milligram per dl, then she is not diabetic. If it comes between 120 to 140, she is chances of moderate diabetes, and if it is more than 200 milligram per dl, then she is maybe a case over diabetes. So this one-step test is very comfortable test, and it needs no frequent visit for the patient. We do this in first visit, then in 28 weeks, and then in 32 weeks, 34 weeks.
Right.
Thank you.
Very simple. Only 75 gram of glucose, irrespective of whether she has taken food or not taken food. We do this screening, and result is very easy to do. And if it is more than 140, diagnosis of gestational diabetes is done. And because we have in the ethnic group, so universal screening is mandatory for us. Why it is important to diagnose gestational diabetes? Dr. Rishika.
Gestational diabetes is associated with very high complications to both mother and the fetus, which is very easily preventable if we diagnose it early during the pregnancy. So we have to diagnose it as early as possible during the first antenatal visit.
At what period of pregnancy does gestational diabetes usually develop? One word.
It develops in second trimester from 24 weeks onwards.
Thank you. What are the possible maternal complications of gestational diabetes in pregnancy, Dr. Madhu?
Whenever any woman with diabetes mellitus, they come to us, first of all, when the patient is diagnosed with diabetes, and these patients, we must be very alert during the antenatal period, because most of the patient, they comes with recurrent urinary tract infection or vaginal candidiasis. Many patients, they suffer from polyhydramnias, which can leads to polyhydramnias, preeclampsias, pregnancy induced hypertensions, and many complications that are present during the antenatal period. And even these patients, when they go into labor, there is always risk of prolonged labor and obstructed labor due to large size baby. And there may be vaginal canal injury, birth canal injury, there may be. And also the patient, they suffer from abruptio placentae, which can leads to sudden fetal death. These are the very rare.
Well, Dr. Madhu, what is the incidence of preeclampsia in diabetes?
30 to 40%. 24%.
Okay, 24 to
20. Yeah,
threefold increase.
Increase in preeclampsias.
Name, what is the pathophysiology of polyhydramnias? Dr. Ishika.
High maternal blood sugar passes through placenta and causes fetal hyperglycemia, which leads to fetal polyuria, leading to polyhydramnias in pregnancy.
Is there more risk of ketoacidosis? Dr. Naveen.
Yeah, it's more prone to ketosis, because in case of pregnancy, free fatty acid oxidations for the fuel for fetus is necessary. In that cases, the ketosis is developed, the free fatty acid oxidations, ketone body form, and they are more prone to ketosis, especially during the labors or before labor, when the steroids are given, and that leads to the ketoacidosis.
Is it common in pregestational or GDM? Which is more prone? Pregestational or GDM?
GDM.
No, sir. In pregestational diabetes.
It's a pregestational.
In pregestational, because
over
that
diabetes.
is the chronic disease. So kidney is already involved.
Yes.
So in pregestational, there is more chance of ketoacidosis. What is the main fetal problem associated with gestational diabetes?
Sorry. Macrosomia, that is the increased birth weight, increased weight of the fetus due to the hyperglycemia that leads to the insulinogenic action of the lipid genesis, that causes the macrosomia. And the other malformation like neural tube defect, spina bifida, shoulder dystocia. These are the neonatal complications in the fetal.
Okay. What is the cornerstone of management of this pregnancy, Dr. Sameem?
You are asking for GDM. For every, whether diagnosis is GDM or known type 1 diabetics or type 2 diabetics, management starts from the pre-conception counseling. If patient is known type 1 or type 2 diabetic, patient is asked to maintain her blood glucose and HbA1c level less than 6.5% to get ready to conceive. So first and foremost is the pre-conception counseling. After that, if patient is already diabetic and she has conceived, then physical activity, nutritional therapy is the second most important treatment or management of this. Even if the patient is not achieving their blood sugar target or HbA1c target, then we move to the pharmacotherapy, which is mainly based on insulin therapy.
Well, Dr. Sameem, so the tight glycemic control is the main cornerstone of management of this type of patient.
Yeah.
Now, you come, how will you manage the woman with the gestational diabetes? Dr. Sameem, please.
First, I have already discussed. First is the lifestyle modification, then medical nutrition therapy, and then if patient is not achieved by these things, by doing physical activity and medical nutrition therapy, then we move to the pharmacotherapy. Among pharmacotherapy,
we will come on first on the medical nutrition therapy. What is the calorie requirement? Can you tell me?
Calorie requirement is 30 kilocalorie per kg of body weight. Usually, it should be limited by the 40 to 45% of carbohydrate, and saturated fats or fat intake should be much less than 35%. Among these, saturated fats do not constitute more than 10% of the total fat.
Okay. So, the medical management is very important, and very easily we can remember 40 to 45% of the calorie from the carbohydrate. फिर से 10 कम करेंगे 30 to 35% from the protein, and फिर उससे कम करेंगे 25% from the lipid. And so lipid is particularly protein is particularly lean protein. And if the patient is obese, the calorie requirement is more or less, that is 25 kilocalorie per per kg per day. Dr. Naveen, what practical advice will you give her regarding 3 meals?
We advise, particularly in the gestational diabetes, 3 major and 3 minor, but we split in a small amount, because after the breakfast, the insulin secretion is blunted as compared to the normal women. So we split breakfast in 2 parts, lunch in 2 parts, and the dinner in 2 parts. So the postprandial glycemic excursion should be low.
Thank you. So this question covered. What is the purpose of bedtime snacks, Dr. Naveen?
Bedtime snacks should be given to avoid hypoglycemia and the early morning starvation ketosis. We know the starvation induces the ketosis, so the bedtime snacks or spurt should be given in this patient.
So we are just doing the dietary modification, and how long can dietary modification alone be tried in this woman, Dr. Sameem?
For 2 weeks, if patient is not achieving their sugar target in 2 weeks, then we move to pharmacotherapy.
Okay. And if he sees in the 3rd trimester, only 1 week. If the second trimester, 2 weeks. If in the third trimester, 1 week only. What is the role of exercise in pregnancy with diabetes patients? What will you recommend and what you will tell, Dr. Samim?
Hello. In general population or general diabetic patients, 150 per minute per week, 150 minute per week exercise is advised. Similarly, in diabetic patient, it is also advised that moderate physical activity, if it is not restricted by obstetric complication, physical activity or exercise should be prescribed. So what should be the frequency and what should be the duration? So most of the guidelines recommend 20 to 30 minutes per day for 2 to 7 days of duration per week.
Okay. When will you consider insulin in this patient? Dr. Naveen?
Yes. During the first 2 weeks, we checked twice weekly. If it's not controlled, we can start insulin in this patient.
What insulin will you prefer and how will we give? Dr. Samim?
First, we will start with short-acting insulin, like pre-meal insulin, because mostly in GDM, mostly postprandial glucose is raised. So first, we will try with pre-meal insulins, which is short-acting or ultra-short-acting. If patient is not achieving the blood sugar target, like post-meal blood sugar less than 140, 2 hours after the post meal, if patient is not achieving less than 140, then we can add or intensify. So in addition, if patient is not controlled on short acting insulin, then we can add intermediate acting or long acting insulin.
Well, if regular insulin doesn't achieve the glycemic target, then what we will do?
Then I have
okay.
I have already told.
What should be the
intermediate acting insulin, neutral protamine hegden, NPH will be added, or
basal bolus insulin is the gold standard. Yes. Every pregnant lady with diabetes is different. Sometimes you may have the fasting problem, sometimes you may have the PP problem. So you have to customize and individualize each other. And the insulin which can be safely taken on the long term basis, we have got the maximum experience with intermediate NPH insulin and soluble insulin. But newer synthetic insulin have also come. Among that, glargine is gradually accepted, though Detamir has got the maximum trial. And there is a Novo Nordisk based powered study which is suggesting that degludec in future they can also be accepted. They have applied for approval in FDA. And if the postprandial is increased, then you have to give the short acting insulin, short acting synthetic insulin. And if it is still not controlled, then postprandial walking has also come to stay. This is short about insulin. Just to.
Sir, one thing I would like to add. In ADA statement, glargine has been approved for the use during pregnancy and it is being widely used.
Yes, this is true. The glargine has been approved. 2 years, up to 2 years ago, we were selling that this American College of Gynecologists, they are advocating glargine. And if the patient is already on this molecule before pregnancy, in the cases of pre-gestational diabetes. But now it is in the this 25 recommendation, they have been approved by ADA.
Degludec is being used, but the problem with Degludec is we have to slow titrate because of its half-life is longer. So we have to be very cautious in up titrating the dose of Degludec. But Degludec is also being used.
Well, we have to aim that blood sugar fasting interval should be below 95, 1 hour postprandial below 140, and 2 hour below 2 hour postprandial below 120 milligram. This should be our aim. These are the ADA recommendation at present. How should blood glucose monitoring be done? Dr. Anju ma'am.
In gestational diabetes, at least thrice a day, first fasting, and 3 after each major meal. And in diabetic patient, gestational diabetes, at least 3 before major meal and 3 after major meal. And one sometimes if she is having regular morning hyperglycemia at 3 a.m. in the morning. So these are the recommendations.
How will we manipulate the insulin dosage to achieve better control? That is already discussed. Which has the correlation with macrosomia, fasting or postprandial? Fasting. Any problem if glucose control is too tight, Dr. Lata?
Very tight control may not be desirable in women because there can be development of small for growth babies, IUGR. So whenever there is associated vascular disease and hypertension, they are the causes for the placental insufficiency. So tight monitoring is not advised.
Can oral hypoglycemic agent be used in gestational diabetes? Dr. Madhu?
Usually before we didn't use any oral hypoglycemic drug, but nowadays we use metformin, which is safe in pregnancy, and we can use it.
The follow-up scan in these women. Okay.
Among the oral hypoglycemic, metformin has got the maximum trial. MIG trials suggested that one arm was ladies, pregnant ladies with metformin and insulin if required. Other arm was insulin arm. And it was seen that in the combined arm, in the metformin arm, the macrosomia were less, the complications were less. The ladies accepted it more. So that is there. And I don't agree with this slide where it shows that glyburide doesn't cross placenta. In year 2000 or so, liquid chromatography and other methods were used, and they did not detect that it crosses placenta. But now we are sure that even 50% of the drug may cross the placenta. And as a result of that, there may be neonatal hypoglycemia and macrosomia also. So that is not the preferred molecule. First molecule is metformin, MIG trial, MIG tofu trial. We are not have time to discuss all those. And they are even considered before 20 weeks of pregnancy also. Different trials are there. This is not the correct platform to discuss in detail all those things. Glyburide will come after metformin.
But insulin is the drug of choice, sir.
Yes,
we usually use in pregnancy.
Insulin remains the drug of choice for pregnancy. There is no doubt about that. But 4 pricks will make any lady nervous sometimes. And ours is the insulin phobic country, where the patient will come to you and say that Dr. Sahab, kuch likhiye, insulin mat likhiye. You have to motivate them to take insulin. सुई नहीं लेंगे, लेकिन उनको मोटिवेट करने का मेरा तरीका है, कहते हैं कि
जब उसके बेबी पर आता है ना, then they agree कि we will do anything for our baby.
नहीं,
and they get ready to take insulin.
This is the correct psyche. अगर आप इंसुलिन लेंगे और शुगर ठीक से कंट्रोल होगा, तो आपका बच्चा कृष्ण भगवान की तरह सुंदर होगा. and that motivates the patient.
Can the treatment be customized based on fetal ultrasound parameter, Dr. Lata?
Actually, this is a very new concept, and it is also showing benefits. Now, every 15 days, the fetal abdominal circumference is measured, and then it is said that the dose adjustment can be adjusted according to this. So, this will help in identification of patients who are having high risk and who carry the bad perinatal outcomes. So, in this, the measuring the abdominal circumference definitely helps.
Now, what is the cause of unexplained intrauterine fetal death in these cases, Dr. Anjana Prasad?
In diabetes in GDM, this is a very bad picture. When we suddenly see that the baby is not moving, baby is less moving, or baby is not moving, this is a bad picture. Actually, it happens due to so many causes. Because this hyperglycemia causes this baby becomes macrosomic, and there is RDS also, respiratory depression, and placental insufficiency causes SDS also, small for growth retardation. So when we do not check the proper level of proper glycemic control is not there, then this exceeds and all of a sudden the baby will die in uterus, and this is a very, very bad scenario when we have nothing to explain that why this baby is dead. So we have to very meticulous in glycemic control and see the level of patient's glucose, whether, and monitoring the tight biophysical fetal monitoring is very important to see the baby's health in uterus.
Thank you. Dr. Jha, will you give me 10 minutes more?
This is a very difficult question for me to answer because of the threat at home. A threat at home in specific terms, and in larger terms, Nari Shakti of Sitamarhi. So I bow down to the 10 minutes request, but kindly finish before 10 minutes.
Okay, thank you. What is the Patterson hypothesis, Dr. Rishika? Very, very crisp.
Maternal Peterson hypothesis predicts that when the sugar levels are high and it crosses the placenta, and insulin being a high molecular weight substance, doesn't cross the placenta. So maternal hyperglycemia leads to fetal hyperglycemia, which in turn stimulates the fetal pancreas to produce insulin, leading to hyperinsulinemia. It acts like growth factor and deposits fats around the shoulders and abdomen specifically, leading to all the fetal problems.
What is the place of Doppler in antepartum fetal surveillance, Dr. Lata? Abhi.
Actually, in a compromised macrosomic fetus, the Doppler is not very useful, but it can be useful in pregnancies which are associated with complications of vasculopathy and intrauterine growth retardation.
What is the best method to evaluate the fetal condition in diabetic pregnancy, Dr. Pratima?
The best method to evaluate is non-state NST test, and it should be done twice weekly starting after 32 weeks of gestation. And another alternate biophysical profile is fetal biophysical profile. Maternal fetal movement counting should be it also should be encouraged by that is the kick count.
Which is the ideal timing of delivery in gestational diabetes, Dr. Madhu?
In any patient, if blood sugar is well controlled, we allow the pregnancy to go to 38 to 39 weeks. But if blood sugar is not controlled, usually we either we induce or we go for cesarean sections. If baby is matured and blood sugar is well controlled, then we can go for either for inductions or for cesarean sections. But if blood sugar is well controlled, we can allow the pregnancy to go to 38 to 39 weeks. I don't go to 40 weeks.
What is the place of cesarean section, Dr. Pratima, in this case? Elective cesarean section.
If elective cesarean section should be done if there is obstetric complications. Otherwise, we should be, as Dr. Madhu said, we should wait for the normal vaginal delivery.
If the weight of baby is more than 4 kg, rather 4.2 or 4.5 kg, we should do elective cesarean section. Otherwise, there is chance of shoulder dystocia. Which is the most common method of neonatal problem, Dr. Pratima?
That is the hypoglycemia, neonatal hypoglycemia. This is the most common complications.
What are the complications specific to pre-gestational diabetes?
Abortions and congenital malformation are specific for pre-gestational diabetes. Abortion in the first trimesters usually.
We all know why congenital anomalies are less common in gestational diabetes, because what the malformation occurs, it occurs in the first 2 months. So, it occurs in the mid or late pregnancy, so it is more common in pre-gestational diabetes. Which malformation are more common in pre-gestational diabetes?
Cardiac malformation and neural tube defect.
Which is specific?
Caudal regression syndrome.
It is very rare. What investigation are mandatory in pre-gestational diabetes? Nowadays, we are getting pre-gestational diabetes very good numbers, and its number is getting to be increased day by day. So, what the investigation are mandatory in pre-gestational diabetes?
Renal function test, we can kidney function test, we can do fundoscopy and urine culture and HB1C that we are in day-to-day practice, we are glycosylated hemoglobin.
Actually, diabetes in pregnancy or diabetes itself is a multidisciplinary approach. It needs multidisciplinary approach. So, it needs a pediatrician, physician, endocrinologist, renal, all to get good result. बहुत हो गया हाँ When is the termination of pregnancy advisable in pre-gestational diabetes, Dr. Anju ma'am?
In pre-gestational diabetes at 38 weeks, in well controlled, when blood sugar is well controlled, and if uncontrolled, then we can deliver her early, but we have to choose between prematurity and stillbirth, because diabetic babies are, in them generally lung maturity occurs late. So we have to take notice of that.
What are the relative proportion of pre-gestational and gestational diabetes respectively?
90% patients are having GDM and 10% patients are having diabetes mellitus, pre-existing diabetes. 90 is to 10.
What advice to be given to women with gestational diabetes after delivery?
After delivery.
But khatam ho gaya sir mera.
Yeah, after delivery, the glucose tolerance test should be done after delivery, and then at 6 weeks postpartum, and then at 6 weeks postpartum, सुनो हम बोल रहे हैं. And then at 6 weeks postpartum, and if the blood sugar is normal, then yearly we go for screening, and if the blood sugar is not normal, then generally we advise the patient to go to diabetologist or physicians.
6 days, 6 weeks and yearly.
6.
Even if it is normal, she has to be followed up.
Yeah, for 1 year, yearly one.
At least 50% ladies become diabetic.
Even their offspring also suffer, can suffer from diabetes. So
what is the contraception you will advise and why?
Yeah, we usually advise the contraceptions. Either they can use barrier methods or IUCD, and if they want pills, progesterone only pills can be advised.
low dose OC pills can be advised.
But usually we don't prescribe OC pills.
Breastfeeding?
Breastfeeding is strongly recommended because it reduces the risk of type 2 diabetes mellitus in the mother also, and it reduces the risk of obesity and diabetes in the child also. And it should be exclusively for the first 6 months.
In last, we should care the lady in pre-delivery period, pre-pregnancy period, during pregnancy, during ANC, during delivery, after delivery, so that we can get a good healthy baby, a healthy mother, as well as a healthy nation. Thank you.
Excuse me, I want just 1 minute. Whenever we get patient of diabetes mellitus and we refer to the physicians, and they come and ask us, कि मैम क्या खाना है? Then I only request to all the physicians. So I only request all the physicians to at least give one printed sheet in which all the diet, what they should take in the morning, evening, or just because they ask, they come and ask us. And I see many patients, when they are referred to the physician, the blood sugar is not well controlled, and they just increase the dose of insulin. And when I inquire from the patient, one thing I have found that they are not controlling the diets, as well as they are not doing any physical activity. And what we advise them, so I just only request to you all also, all the physicians, so you must tell them about the diet and about the exercise, because many times blood sugar is not controlled. What you say, Samim, Dr. Samim? No, they should give. No, I haven't seen any. Just it is written diabetic diet. So they should know now what is the diabetic diet. They should give in printing.
The suggestion is well taken. Many of us are already giving. Those who are not giving, from today onwards will give. You are also authorized to give, but if the onus is on physician, we are too glad to accept it.
Many times the blood sugar is not controlled because they are very inactive.
Yes.
Dietary management is the most difficult
and
part
physical
of
activity.
One
I will give.
To me yesterday,
And about the exercise,
she takes the insulin injection.
20-minute exercise after 30 minutes of meal will definitely decrease the requirement of insulin.
Increases insulin sensitivity.
Motherhood is the best gift of God to ladies, and it is a great challenge to carry out a safe pregnancy amongst hyperglycemia, and we have learned quite a lot today evening how we can do that and how we can take the blessings of pregnant mother. And to cut the long history short, I will just pass on the message that you should remember 3 figure: fasting 1995 whatever, 95 ADA, Indian 190, 1 hour after meal 140, and 2 hours after meal 120. You remember the 3 magical figures. You will save not only the mother but in the fetus also, not only in the present tense but also in the future tense also. And with this, I know that this is one of the hot favorite topics of our national president, Professor ANUJ MAHESHWARI, a word or two, valuable words or two from him.
I'm really very much impressed of this high level of discussion what I could see here in Bihar, Sitamarhi, and knowledge is highly appreciated what I could learn from the panel this here, which is present here. But few things I must tell you regarding the gestational diabetes management, because why I am coming here on the dais, because gestational diabetes is very important for the prevention of diabetes in the future. What the level of rise we are seeing in our country, that diabetes is rising, which was about 2.2 crores in 2000, now it is more than 100 billion. We can say that 1 crore, more than 1 crore, 1.1 crore is there. And at that time it was 22 lakhs in 2000. So it is 5 times increase has already done in these 20 years. And this is, and big reason behind this is the gestational diabetes. Because gestational diabetes earlier was considered as a physiological phenomena. People used to say, most of the endocrinologists used to say in 2000 and 2002 that it is a normal thing, it has to happen. प्रेगनेंसी है तो उसमें ग्लूकोज लेवल बढ़ेगा ही, तो उसके लिए इतना डरने की क्या ज़रूरत है, उससे इतना परेशान होने की क्या ज़रूरत है. बट करेंटली वी हैव द डाटा, वी हैव द एविडेंसेस दैट gestational diabetes or unmanagement or not management of glucose level up to the level what our gynecologist suggested here, that 92 fasting or less than that and 120 at any other time of the day is recommended. May it be postprandial, may it be any other time of day, this should not be more than 120. Even at this level, the evidences suggest that 4 and 5 macrosomia shall be happening. But below this we cannot go because of the risk of the hypoglycemia, risk of the inconvenience to the mother. As of now, we have not got any evidence that hypoglycemia is injurious in the pregnancy. Many of the people may not be knowing, except these gynecologists, that lowest level what a mother touches in a day during pregnancy, that is 55. And it happens at the midnight around 2 a.m. So 2 a.m. a mother reaches to the 55 and it does not cause any symptom, any hypoglycemia picture comes up, because at the same time anti-insulin hormones are also very much active. So they take care of this hypoglycemia very easily, and because of what, hypoglycemia does not become symptomatic during the pregnancy and it does not cause any harm to the child, fetus and mother, anyone. Second thing important, that mother, हम लोगों ने करीब 2007 से 2010 तक एक कैंपेन चलाया था, जिसका एक पार्ट हमने बिहार में भी किया था. I don't know, few people might be here, those who have attended that session we did at in Patna. And this campaign was under the Jagran Pahal. Dainik Jagran was the newspaper which has taken a NGO, and with that we have done in few selected cities. In that campaign we have given this slogan, एक जान से बचे दो जान. तो एक जान से बचे दो जान का माने ये कि एक, अगर हम किसी प्रेग्नेंट वुमेन को स्क्रीन कर रहे हैं तो हम ना सिर्फ आने वाली नस्ल को बचा रहे हैं डायबिटीज़ होने से, बट वो प्रेग्नेंट वुमेन जिसका हम स्क्रीनिंग कर रहे हैं, शी इज़ ऑल्सो गोइंग टू बिकम 5 to 10 years after the pregnancy diabetic, type 2 diabetes. So we are also saving her to become the diabetes. So it is not only a question of the next generation, this is also on the present generation, especially the mothers, those who are surviving. Many of the my gynecologist friends at many places say, हमारा तो 140 पे भी आराम से हो जाता है, कोई दिक्कत नहीं होती, 200 पर भी हम तो डिलीवरी करा देते हैं, कोई हो तो जाता है, प्रॉब्लम भी नहीं होती. लेकिन that child who is taking birth at 180 and 200 will become diabetic at 20 years and 25 years of the age. And this is the reason because of what the occurrence of the diabetes is coming up earlier and earlier. पहले 60 साल में होती थी, मुझे याद है जब मैं MBBS में था तो मेरे टीचर्स कहते थे 60 साल के ऊपर का कोई आता है तो उसी में शुगर चेक करना. फिर 40 पे आया जब मैं MD कर रहा था, एंड नाउ इट हैज़ कम टू द इवन 20. 20 साल के ऊपर का भी कोई, इवन 20 साल के नीचे के लोगों को भी टाइप 2 डायबिटीज़ मिल रही है. सो दिस इज़ one of the, I don't say that it is only because of the GDM poor management. The GDM management is one of the most important part. तो हमें GDM क्यों मैनेज करना चाहिए? इसलिए नहीं कि डिस्टोशिया ना हो जाए, इसलिए नहीं कि प्रेगनेंसी सेफ हो जाए, इसलिए नहीं कि डिलीवरी सेफ हो जाए, इसलिए कि हम अपनी फ्यूचर जनरेशन और प्रेजेंट जनरेशन दोनों को डायबिटीज़ होने से बचा सकें. कितनी डेट्रीमेंटल है उसके बारे में तो हमारे प्रीवियस स्पीकर ने, दोनों ने जिन्होंने डिबेट की थी उन्होंने बात किया था. इसके बाद when should it be screened? So none of our panelists has said that it should be screened at the first contact. First contact. कहा था तो शायद मैं सुन नहीं पाया होगा. But 24 to 28 weeks is not the right time. जब भी आपको पहले पता चले कि ladies get. In fact, that is also not the right time. Ideally, you should motivate the females to get it before entering into the pregnancy. They should get themselves screened, and if they are not meeting the criteria, they should postpone their pregnancy. 6 महीने बाद, 8 महीने बाद जब उनका क्राइटेरिया मीट करे तब उसके समय वो. वेट लॉस इज मोस्ट इम्पॉर्टेंट थिंग. बहुत सारे लोग कहते हैं कि प्रेगनेंसी में वेट लॉस शुड नॉट बी डन, बट प्रेगनेंसी में स्पेशली दोज वीमेल आर हैविंग द हाई वेट, those females are having the diabetes, they should be recommended to keep their weight gain minimum possible, and that criteria has also been given. 10, not more than 10 kg weight gain should be done in the pregnancy, the women, those who are having the diabetes as well as obesity. So management arm में जहाँ भी हम लोगों ने बात करी, of course most important is the postprandial. India is very much different than ADA, American. Most of the time we quote the American guidelines, but American guidelines are actually not made for us. They are made for Americans. They are made for the Europeans. They have different race. वो Caucasian race है. हमारी जो Asian race है, that is much different than them. So we do not belong to them. तो हम उनकी guidelines क्यों follow कर रहे हैं? None of the panelists has talked about the Rssdi guidelines. None of the panelists has talked about the DIPSI guidelines. But we should focus more on the Rssdi and DIPSI guidelines because they are for the Indian perspective. Then diet management, you people know very well. बहुत अच्छे से बताया आप लोगों ने कि इस breakfast को 2 पार्ट में डिवाइड कर लेना चाहिए. But still we are not agree about the level of exercise, level of physical activity what we should recommend during the pregnancy. There are multiple unanswered questions which has to get the answer. For that purpose, I have started a talk with the FOXI President Dr. Bhaskar कि हम लोग बहुत जल्दी RSSDI एंड FOXI का एक जॉइंट डिक्लेरेशन एंड जॉइंट गाइडलाइंस लेकर के आएंगे, जो कि अभी तक जैसे आपने देखा होगा ADA एंड उनका अमेरिकन कॉलेज ऑफ ACOG एंड ADA का जॉइंट डिक्लेरेशन है. उसी तरीके से वी विल ट्राई टू गेट द ICOG एंड RSSDI जॉइंट डिक्लेरेशन दिस ईयर ओनली, सो दैट वी ऑल रिमेन एट द सेम प्लेटफॉर्म. All physicians and all obstetrician should suggest the same thing to all the patient. ये नहीं कि कोई ADA के बारे में बता रहा है, कोई ESD के बारे में बता रहा है, कोई इंडिया की गाइडलाइंस के बारे में बता रहा है. So these are the few important things which I wanted to share. Thank you very much for giving me this opportunity.
Okay, thank you, sir. Now over to Dr. Jha.
Now I will request Dr. Renu Singh ma'am to kindly come to the dais and honor Dr. Anju Singh madam. Dr. Renu Singh ma'am and Dr. Sudha Jha to honor all in the interest of time. All the erudite panelists, one of which is sitting in the audience also. You can come on the dais to receive this thing. Samim. Dr. Sneha, please come. Dr. Susma, please.
नीचे खड़े हो जाइए।
I will, Dr. Naveen to be honored
by Dr. Lata Gupta.
By Dr. Lata Gupta. Sneha to honor Rishika. Dr. Naveen to honor Dr. Sudha Jha, moderator. After this, जिनका बच गया वो कह के ले लें। और सभी पैनलिस्ट और मॉडरेटर से रिक्वेस्ट है कि नीचे आ जाएं फॉर ए ग्रुप पिक्चर, एंड इन द मीन टाइम आई विल बी कॉलिंग chairpersons on the dais for the next this thing. Next session, next two sessions are going to interest our surgeon segment quite a lot. To talk on peri-operative management of diabetes, we have chairman-elect Rssdi Bihar chapter, Dr. SHAIBAL GUHA, and to chair the session, Dr. J.K. Datta, Dr. Rashid Kumar Singh, Dr. Alok, and Dr. Siddharth. खाना छोड़ दो. Please, chairpersons are requested to kindly come to the dais and introduce our erudite speaker.
Good evening, everybody. Today we are here in a wonderful CME organized by Rssdi Bihar and Sitamarhi chapter. With the growing menace of diabetes and ferocity of the diabetes that we are coming across as an anesthesiologist, I started practicing anesthesiology 25 years back. At that time, we rarely used to have a diabetic patient in OT, very few. But on an average, if I get 4 cases done, at least 2 or maybe more are having comorbid conditions, including diabetes nowadays. So it becomes imperative to know about the latest guidelines of and how to manage perioperative diabetes. And at the same time, while I started practicing, and now there are so many wonderful drugs which have come into the management of diabetes, like DPP-4 inhibitors, SGLT2 inhibitors, and how to manage those drugs which either the patient is taking or in the management of diabetes you need. There is no speaker better than Dr. SHAIBAL GUHA, who is here, who has come all the way from Patna to give an insight on how to manage diabetes in perioperative period. He needs no introduction. Yes, he is an MD medicine and he is the director of Positive Health Center, Boring Road, Patna. He is presently working as Associate Professor, Department of Medicine, Netaji Subhash Chandra Bose Medical College, Bihta. He was formerly Registrar, Department of Internal Medicine, IJMS Patna. He is ex-senior resident, Escorts Hospital and Research Center, Faridabad, New Delhi. He is presently the chairman-elect Rssdi Bihar chapter. He is also the secretary CCDSI Bihar and Jharkhand. He is the past secretary of API Bihar, and he has spoken on various platforms across all the platforms like Epicon, RSDI, Epicon. So please, Dr. SHAIBAL Kaha, please enlighten us with your speech. Thank you.
Thank you, sir, for the kind words. Pranam to all my seniors and good evening, dear friends. First of all, I would like to acknowledge and thank our National President of RSDI, Dr. ANUJ MAHESHWARI, sir, and our National Executive Committee member, Dr. V.K. Singh, sir, for gracing the occasion and sparing 2 days of time with us, today for the CME and tomorrow for the proposed patient outreach program which we are planning to have. And thanks to Dr. Sudhir sir and Sudha ma'am for being excellent hosts and organizing this meet. When we were discussing the topic of discussion, Sudhir told that we will be having a mixed audience including surgeons and gynecologists, so I thought the best topic would be to talk about perioperative management. That would be of relevance to most of the speakers. So I'll be just briefly discussing the basics of diabetes in perioperative care, the various protocols which are involved and the pitfalls which are there. So why is this important? It's important because there is being a patient of diabetes and who is planned for surgery, the patient is at an increased risk of infection, the wound healing is poor, the cardiovascular and metabolic complications risks are much more in these patients, and we all know that both hypoglycemia as well as hyperglycemia increase mortality. And as we were discussing over the last couple of hours, diabetes is gradually becoming more and more common, and it's present in about 15 to 30% of surgical patients. In fact, 20% of patients undergoing general surgery are diabetics, about 50% of patients undergoing general surgery have pre-diabetes, and around 30 to 80% of patients undergoing cardiac surgery have been seen to have hyperglycemia. So that's the prevalence of diabetes among patients who are put up in the OT, and so we should always know how to manage these patients. So what is the pathophysiology of perioperative dysglycemia? It's basically stress due to surgery, stress due to anxiety, stress of the underlying disease. All of these leads to increased catecholamines, which increase in cortisol, increase in glucagon, leading to increased hepatic glucose output. The stress also increases by the fear, fright, flight mechanism. It increases insulin resistance and reduces insulin secretion, and this all leads to hyperglycemia. Also, if we talk about surgery, certain anesthetic agents also cause perioperative hyperglycemia by increasing the level of cortisol, causing insulin resistance. Notably, sevoflurane, isoflurane, desflurane are among the few inhalation anesthetic agents which are known to cause hyperglycemia, and propofol and ketamine are also among the parenteral anesthetic agents which do cause hyperglycemia. So we should keep this in mind as well. Patients can be stratified into high risk patients when they are put up for the OT. High risk patients consist of type 1 diabetics, patients who have diabetes for many years, then patients with complications like renal failure or coronary artery disease, and patients who are undergoing emergency surgery where the surgeon doesn't have time to do a proper pre-op workup. So those are basically considered high risk patients and have to be looked into with more caution. The goals of perioperative control are basically to prevent hypoglycemia, this first and foremost importance, and at the same time we should also avoid severe hyperglycemia in that patient, because that's also deteriorates the patient's morbidity, increases the patient's morbidity. And we should also prevent ketoacidosis, prevent hyperosmolar coma, and all these are basically done to reduce the chances of infection, reduce the duration of ICU stay. The target of glucose control during the perioperative period is, as per all the guidelines, is somewhere between 140 to 180. And hyperglycemia, we all know, during the operative period is an independent marker of adverse surgical outcomes. Various guidelines are there, but all of them are almost the same. Like the ADM mentions that 100 to 180 is the target for non-critically ill hospitalized patients. It can be increased up to 140 to 180 in critically ill patients. However, in patients undergoing cardiac surgery, it's more stringent. The sugar should be kept between 110 to 140. Similarly, the Society for Ambulatory Anesthesia, they also mentioned that it should be less than 180 mg per dl. Society of Thoracic Surgeons also say that maintain intraoperative blood glucose less than 180 and pre-meal less than 110. So the reasonable goal as per consensus of all the guidelines is that we should keep the sugar levels somewhere between 140 to 180. So there are certain caveats when we are talking about glucose measurement. Glucometer capillary blood sugar test is often affected by perfusion, anemia, erythrocytosis, edema, and by certain medications, and we should always keep this in mind when we are watching the sugar levels in a patient who is put up for surgery. We often get false high values when the patient has had maltose, galactose, xylose, or N-acetylcysteine, acetaminophen, dopamine, uric acid, and patients with low hematocrit. So these can give rise to false high sugar values, and we should keep this in the back of our mind. False low values, on the contrary, can be obtained when the patient has been administered furosemide or patient has a high hematocrit level. Similarly, false high and low values sugar can be ambiguous in patients who has recently taken vitamin C just before the sugar test. So protocols are basically based upon three different stages: pre-op phase, intraoperative phase, and the post-op phase. When we are considering the pre-op assessment, we have to assess the type of diabetes, whether it's type 1, type 2, or secondary diabetes. What is the duration of diabetes? What are the complications the patient has? What medications the patient is currently on, oral as well as insulin? And how good is his glycemic control in the last few months or years? And the various complications that the patient has, like renal complications, cardiac complications, or neuropathy which the patient has, because all of these somewhere interfere with the glycemic management, and we should keep that in mind. A1C has a role to some extent because it reflects the chronic glycemic control, and hence it has been shown that if the A1C high is somewhere between 8 and 9, it increases the perioperative risk. And its A1C is, however, not for acute glucose adjustment, as we all know, and it definitely, but it helps plan the post-operative insulin requirements. So pre-operative, the basic guidelines are that we should avoid prolonged fasting. The capillary blood glucose before surgery has to be taken to rule out hypoglycemia or hyperglycemia. Surgeries should ideally be planned in the morning, and IV dextrose should be kept in hand if prolonged NPO is planned in that particular surgery. If when the patient is on oral antidiabetic drugs, there are certain rules about the drugs, like metformin ideally should be stopped on the day of surgery. Sulfonylureas also should be stopped on the day of surgery. SGLT2 inhibitors, now most of the diabetic patients are on SGLT2 inhibitors. So this is a request to all our surgical counterparts, surgical colleagues, that you should be very watchful about this molecule, and if the patient is on SGLT2 inhibitor, this ideally should be stopped at least 3 days prior to surgery because of the risk of ketoacidosis. Then DP4 inhibitors are usually safe and can be used, but GLP-1 receptors should also be withheld on the day of surgery. The surgery should be ideally done in the morning to minimize the duration of fasting and minimize risk of hypoglycemia. As I mentioned, anti-diabetic medications should be adjusted. The dose of basal insulin analogs is reduced to 75 to 80% on the night prior to surgery. Patients on twice daily glargine and ditamate, again 20-25% dose reduction is advised. Dose of NPH again should be reduced by 50% on the morning of surgery, and patient on premixed also should be shifted to long-term basal, and again the dose reduction should be done by 50 to 70%. This is a simplistic chart which shows that evening before surgery, we need to reduce the dosage of long-acting insulin by 75 to 80%, and intermediate-acting insulin and premixed insulin and nutritional. The evening before we can give the normal dose, but morning of the surgery, premixed and correction insulins, we need to either omit the dose and reduce the dose. That's why the surgery is usually planned in morning, so that after the surgery the patient can be given IV glucose or can be given oral feed if the surgery if it is warranted. Then coming to perioperative management. During the surgery, we should not stop basal insulin abruptly and completely. If the patient is on basal insulin prior to surgery, we should rather reduce the dose. Frequent glucose monitoring is advocated. IV insulin should always be preferred in major surgery instead of subcutaneous form. And on the day of surgery, basal insulin dose has to be reduced on the night before. And prandial surgery, if the patient is kept nil by mouth, we don't give any prandial surgery or premixed surgery insulin on the day of surgery. Correction insulin is given as per the protocol. IV insulin infusion is required sometimes. That is usually done when the major surgery is planned, or patient is critically ill, or patient is of type 1 diabetes, or patient has a history of unstable blood sugar levels, or where we are with surgery, we are expecting the surgery to go for long hours, like in case of onco surgery or other certain complicated procedures. In those cases, always IV insulin infusion should be kept in hand, and it's infused as per the protocol to maintain the sugar levels between 140 to 180. Intraoperative glycemic management encompasses regular insulin infusion, hourly glucose monitoring combined with IV dextrose to maintain the sugar levels, targeting the same levels. We should avoid tight glucose control, monitor every 1 or 2 hours, and watch for hypoglycemia under anesthesia. For surgeries lasting less than 4 hours, hemodynamically stable and minimal fluid shift, subcutaneous correction insulin with rapid insulin analogs can be given every 2 hours later on. And for surgeries lasting more than 4 hours, hemodynamically unstable patients, or there is an extensive fluid shift, IV insulin with hourly blood sugar control, hourly blood sugar check is advocated. Now coming to the post-operative phase. In ambulatory patients who are stable, post-surgery with adequate oral intake can be discharged with previous antidiabetic medications. Non-critically ill patients hospitalized in the ward after surgery, those who are not having any oral intake, we should start with the basal and the correctional insulin, like a basal bolus. If there is adequate oral nutrition, we can shift to subcutaneous insulin along with the basal insulin. And basal insulin, a long-lasting insulin to control hyperglycemia, is often used in patients who were earlier on insulin prior to surgery. And nutritional insulin is given to manage the hyperglycemia associated with the meal intake. So that's basically a prandial short-acting insulin, which is preferred in the immediate post-op state. And to calculate the insulin dose, theoretically we go by the formula of 0.4 to 0.5 unit per kg per day. This is the normal average for most of the patients. However, in insulin sensitive patients or patients with type 1 diabetes, some patients who are insulin naive, who never had insulin previously, elderly age group, patients with renal or hepatic insufficiency, the insulin dosage is slightly less, somewhere between 0.2 to 0.3 unit per kg per day. There are certain patients who are insulin resistant, like obese patients or patients who have been on high dose steroids for whatever disease they had. Those patients, the insulin requirement is slightly high, it's somewhere between 0.6 to 0.7 unit per kg per day. For patients on proper meal, we should divide the total dose. Half is given in basal and half as correctional doses. Blood sugar is measured 4 times daily in the immediate post-op period in patients who are not on oral feed. For patients taking oral feed, then with the postprandial and preprandial sugar are measured, and we prefer a correctional prandial insulin, and 50% insulin is given in the basal form. Regular insulin is preferred and blood sugar is measured hourly or 2 hourly, and as soon as the patient has started taking oral feed, we shift it from IV insulin to subcutaneous correctional insulin, which has to be timed with his meals. And total dose is calculated and then it's divided in the different forms. Patients taking adequate calories, 50% basal and 50% as pre-meal insulin as given. Safe transition from inpatient to outpatient can be done. Discharge plan should include clear medications directions, patient education and evaluation of socio-economic issues. A follow-up visit with the physician is or endocrinologist within a month of discharge is always advocated to regularize his anti-glycemic drug doses, and follow-up visit within 1 to 2 weeks is advised. So post-op glycemic control basically entails that resume oral intake as early as possible, shift from IV to subcutaneous insulin as soon as oral feed is initiated. Basal bolus is the standard for in the post-op phase, and we should avoid sliding scale alone. There are certain special situations like type 1 or emergency surgery or patients with renal failure steroid use, where we should be more cautious because we should anticipate complications, and complications like surgical site infections, delayed wound healing, electrolyte imbalance, acute renal injury, cardiovascular events are also should be looked out. And there are certain common pitfalls like omission of basal insulin, over tight glycemic control, reliance on sliding scale alone, poor coordination between different teams, delayed restart of insulin in the post-op period, ignoring the SGLT2 inhibitor risk, inadequate glucose monitoring, failure to individualize targets. These are the pitfalls we should try to avoid. Continuing SGLT2 inhibitors, again I would mention, too close to surgery can lead to euglycemic decay, so we should stop that 3 days back prior to surgery. And we should not stop the basal insulin in type 1 diabetic patients. Again, that's a very important thing to prevent diabetic ketoacidosis, and we should not be over enthusiastic in correcting it. We should not restart metformin too soon. We should take care of comorbidities. If the patient has coronary artery disease or renal disease or neuropathy, we should go a bit slow. Gastroparesis patients may have increased chance of aspiration, so that's one more thing surgeons should keep in mind. So comprehensive pre-op evaluation is needed, and proper handouts to the teams should be given prior to surgery so that the sugar levels are maintained properly. So we should anticipate stress hypoglycemia, we should avoid hypoglycemia at all costs. At the same time, we should prevent hyperglycemia. We should always follow the protocols when you're choosing the insulin, and a proper team approach between the surgeons and the physician always improves outcomes. Thank you for a patient listening.
Thank you for that. Thank you, sir. Any questions in the audience? Sir, actually I have one, sir.
Yeah.
It's about the post-operative period, sir. Supposedly a person is on insulin and is planned for surgery. Immediately post-op, he has to be kept NPO, probably for a day or two, depending upon the surgery. Is sliding scale, the insulin which we give, regular insulin, it's still the gold standard, or are there any changes to it, sir?
Sliding scale theoretically should not be followed because it's basically a reactive approach to treatment. We are treating the sugar level which has already gone up. We should be proactive and prevent that. So that is always said that sliding scale should not be followed. Having said that, it's still the simplest way to control the sugar levels, and everybody is still doing it, but we just need to modify it. What ideally should be done in that case is we should assess the insulin requirement of that patient, what his requirement has been in the pre-op period, 24 hours requirement, because that varies from the person to person. So it may be 10 units throughout the day, it may be 30 units throughout the day. And we should divide that insulin accordingly in the immediate post-op period and give a slightly lesser amount on an hourly basis an infusion if the patient is on kept NPO. And then we can give correctional doses as per the sliding scale. So we should maintain a baseline like 2 units per hour or 3 units per hour as per the patient's previous requirement, and then we should check the sugars every 2 hours something, and then we can give the correctional dose by a sliding scale.
Thank you, sir.
I want to have one question from Dr. Shaibal. Now with lot of patients taking SGLT2 inhibitor, you have rightly told that to prevent euglycemic diabetic ketoacidosis, we must stop it 3 days before surgery. Is there any special test or set of tests which you recommend for the patients who are even after stopping SGLT2 inhibitor come in OT for emergency surgery or elective surgery? Do you have any specific test that you will recommend in those subset of patients?
If facilities are there, we can do an immediate pre-op ABG to rule out any sort of acidosis, and if in the ideal setting that can be done, and if the patient doesn't have acidosis, we can freely go around with treating the patient.
Is there any role of capillary ketone bodies, ketone body estimation?
That has got a theoretical role, but yes, again, but that is only just in the immediate pre-op period that can be.
Yes, immediately pre-op on the day of surgery.
Right, sir.
If you undergo a capillary ketone acidosis sort of estimation, that will give you an idea. This patient is going to have euglycemic diabetic acidosis.
Right, sir.
Because in those cases, there is no blood sugar level is not raised.
Right.
Or maybe slightly raised.
Yeah.
Thank you.
Thank you, sir.
How we adjust the dose of insulin when you are giving the 5% of dose? Just we have mentioned that during operation you give the 5% of dose.
Right.
Then how much insulin you will give? What is your protocol?
Sir, it all depends on the type of patient. If the patient was previously also on insulin,
yes,
we know his
patient was not on insulin,
on oral diabetic,
or he was diabetic on oral hypoglycemic. On that very day, it has been withdrawn.
Right.
Then during post-operative, if I want to give him nutrition dose, then how much insulin I should give?
Sir, if the patient sugar level immediate post-op is almost normal, say between 140 to 180, we can just give a neutralizing dose of GI infusion.
Neutralizing dose in 5%?
Like what 8 units we use. That is
the give 5 units because 1 unit neutralizes the 5 gram of glucose usually.
4 gram.
4 gram?
Yeah.
And how much to supplement?
We usually give 8 units in 5%, 500 ml bottle of 5%. That is the usual tradition what we give, what we prefer, and then we can transfuse that. A GI infusion what we do.
Can you give the Ringer like test post-operatively or not?
If acidosis is not there and if the sugar levels are maintained, and
many people say that only should give the normal saline after post-operative.
We can give a neutralized GI infusion as well, sir. If we are planning to keep the patient nil by mouth for a longer duration, we need to give him nutrition as well. So normal saline won't suffice. We need to give a glucose infusion neutralized with insulin.
Thank you, sir.
Thank you, sir.
In the interest of time and conference, no more questions allowed. Wonderful lecture, Dr. SHAIBAL GUHA. If any questions are there, he can take up in the dinner time. Now I will request chairpersons to kindly honor our erudite speaker. Now I will request chairpersons, Dr. SHAIBAL GUHA, to kindly honor the chairpersons. Thank you, our speaker and the chairpersons. Next topic is very important, which interests all alike, physicians, surgeons, and orthopedic surgeons. The topic is management of diabetic food, physician's perspective. And I have personally seen the slides of Dr. R.K. Modi, wonderful. He will be our speaker. And I request chairpersons Dr. Sunil Kumar Singh, Dr. Syam Kumar Shroff, Dr. Nirmal Kumar Gupta, and Dr. Piyush Raj to kindly come to the dais to chair the session and introduce our knowledgeable speaker.
Good evening, ladies and gentlemen. I have pleasure to introduce the renowned speaker, Dr. R.K. Modi. He hails from Purnia, and initially when he came, he was describing how difficult this journey was from Purnia to Sitamarhi, taking him to 7 hours. So we must pay attention to his lecture, because he is going to tell us about the management of diabetic foot, and he is the director of Modi the Diabetic Research Center, Purnia, and has been a chairman-elect of API Bihar. For now, I invite Dr. R.K. Modi for his speech. Thank you.
Thank you very much, sir, for your kind introduction. Thanks, organizers, for giving this great opportunity. And I first welcome our President, Rssdi, ANUJ sir, to be with us. Welcome, sir. Welcome in Bihar, land of Sita. My pranam to everyone. So, starting my presentation, sir, it has two parts. That is regarding diabetic foot management. First thing is evaluation of diabetic foot. Why we want to evaluate, what we have to evaluate, and how we have to evaluate. And second part is treatment and prevention of diabetic foot. Everybody knows that diabetes is a chronic metabolic disorder that affects nerves, eyes, kidney, blood vessels, and heart. And diabetic foot is the result of either neuropathy or vasculopathy or its combination. But I must say, it is due to ignoropathy. Ignoropathy, ignorance from our side and ignorance from patient side. So both are responsible to salvage a foot. In India, 75 to 90% of the major foot problem is due to neuropathy. And diabetic foot is a major cause of morbidity and mortality with great economic burden, because there is cost of treatment, hospitalization, absence from work. So there is functional as well as financial loss. Now, let us see why we need to evaluate a diabetic foot. Let us see the magnitude, because inadequate management of diabetic foot can result in amputation. That is a very tragic thing. And the commonest cause of non-traumatic amputation is diabetes. About 70% of non-traumatic amputation are due to diabetes. And in every 30 seconds, we lose one limb somewhere in the world, and 50% of the limb with a foot ulcer can be saved. This is the words from American Diabetic Association. So a big thing is there that it is a preventable cause. 85% of foot related problems are preventable. When we see the spectrum of complication, it includes superficial cellulitis to chronic osteomyelitis and even gangrene that necessitate lower limb amputation. Now, we should know some facts about amputation. A diabetic foot ulcer will end in amputation in 85% of cases. 50% of amputation will be either transfemoral or transtibial level. 50% of the patient will have second amputation in less than 5 years, and 50% of the patient die within 5 years. So very tragic. There are few facts about diabetic foot ulcer also, that 15% of diabetic patients will have a diabetic foot ulcer in their lifetime. 15% of the foot ulcer will convert into osteomyelitis, and 15% of foot ulcer will end in amputation. So let us see the common risk factors, and we must ask in history, and we should observe it. Global prevalence is about 1.5 to 16.6%, and the risk factors are very common, like smoking. We must ask in history. Diabetic peripheral neuropathy with loss of protective sensation and peripheral artery disease are important risk factor. Biomechanical factors in the form of foot deformity, callus, corn, bunion, hematose, Charcot joints, all are biomechanical factors responsible for a diabetic foot disease. History is also very important, because if there is a history of foot ulcer or history of amputation, that again becomes a risk factor. Of course, poor glycemic control, visual impairment, retinopathy, nephropathy, all are important. In India, you have bare foot walking, which is very common, is an important risk factor. How does diabetes affects foot? Neuropathy, we know. Vasculopathy, we know. All forms of neuropathy, sensory, motor, autonomic. In motor neuropathy, there is weakness and wasting of muscles, and that results in crowding of toes, cock of toes, hallux valgus, clouding of toes, and that all leads to structural changes that will ultimately lead to functional anatomical deficits. And this results in abnormal pressure point and generation of ulcer. Vasculopathy is also very important. If any patient comes with history of claudication, history of fatigue on walking, wrist pain, that suggests you a vascular disease, and this vascular disease in the form of peripheral artery disease results in ischemia and result in poor oxygenation as well as nutrition to the affected site. So this is the slide showing the interplay between the various factors, neuropathy, atherosclerosis, all forms of neuropathy ultimately giving to ulcer, and it may result in neuropathic ulcer, or when associated peripheral artery is there, there may be neuroischemic ulcer, which is also very common. Now, let us see the spectrum, what we need to evaluate. Patient may have subjective complaints like dysesthesia, that is unpleasant sensation, numbness, burning, pain, tingling, and we can have objective signs, that is null ulcer foot signs. These non-ulcer foot lesions can become ulcerative and can end in amputation if we don't take proper care. And see, this is dry skin, simple fissure. This is callus, that is thickening of the skin due to the continuous friction. This is scorn, painful thickening on the bony prominence. This is blister, again a sign of neuropathy, and it is tinea infection, that is dermophytosis of a wet space. Now, coming to the more serious type of lesions in the form of dry gangrene. We should know this is the line of demarcation that distinguishes it from wet gangrene. In wet gangrene, that is due to venous obstruction, the foot is swollen, warm, tender, and that may result in sepsis. But at the other hand, dry gangrene looks black, and there may be autoamputation. We can see necrotizing fasciitis, which is very common in India because of India is a tropical country. Staphylococcus aureus is most common organism causing necrotizing fasciitis. This is very serious infection because it ascend and go through the fascia. Their subcutaneous tissues and fascia both are affected. We can see here the hammer toes. We can see the tendons. So there is muscle wasting that leads to functional anatomical changes and that giving rise to different pressure points. This is a swollen foot. This is actually a sharp-cut foot. So in any diabetic, if there is first time foot swelling and the foot is warm with an intact skin, there is no ulcer, think of Charcot foot. Here we can see other slide of Charcot. We can see the normal arch, which is a medial arch, which is concave, become convex. There is abnormal pressure point and there is collapse of bone, and that results in ulcer. This is osteomyelitis. Any ulcer which is present over the bone and it is non-healing must do probing, get an X-ray done, and most of the time it is osteomyelitis, and here we can see bone erosion, destruction of the bone. This is about the diabetic foot ulcer. Forefoot is the most common site, and we classify ulcer. This is Wegener classification. My co-speaker, sir, he will detail about the Wegener classification and the diabetic foot ulcer. These are the various foot deformities. These are the vulnerable points for friction. We can see in 4 feet, this is metatarsal, first base of first metatarsal, second, third, fourth. These all are vulnerable points where we get friction, and finally, if there is any injury, there may be ulceration. In midfoot, although this is not a common site, but in flat foot, it becomes in contact with the ground, and there may be abnormal pressure point, and that there may be ulceration also. This is hammer toes. We can see the friction points. In bunion deformity, we can see the friction points. Now, this is very important, that God's greatest gift to mankind is pain. You can just imagine, if there is no pain in myocardial infarction, how dangerous it is. And we should always remember the painless nature of diabetic foot disease. How the ulcer develops. We'll just compare it from non-diabetic to a diabetic patient. In normal food, whenever there is repeated stress, there is inflammation that causes pain, and this pain goes to brain center, and there is gait modification, healing process begins, tissue repairs, and nothing happens. Food becomes normal. But in a diabetic patient, repeated stress or any stress, if it is repeated, any friction, if it is irritated, then there is inflammation, but there is no pain. So no response from brain, continuous use, and that results in non-healing of foot ulcer. So we can see here few practical examples that we see in our day-to-day practice. This is during namaz posture, this knees touching the ground, there is repeated fraction, and this is the result. Callosity develop over the knee. And similar thing happening here when someone is sitting cross-legged in Palthi posture, we can see the malleoli touching the ground. Repeated fraction will give rise to bursitis. Again, these all are preventable problem. I simply advise to my patient to put a cushion when he sits, and that will solve this problem. So even a ill-fitting footwear, that can result in an ulcer. Tight footwear, so must avoid poor fitting shoes that will create friction, and that may result in ulcer in a neuropathic foot. This is Charcot foot. My co-speaker will give details of that. This is the collapsed bone. This is an ulcer. Now, how to detect neuropathy? What you need your will to diagnose neuropathy, because it requires only 2 minutes. You need, because pin, cotton, 120 Hz gauge twinning fork, and 10 gram monofilaments all are present in your clinic. Small fiber function can be diagnosed by simple pin prick and temperature sensation. Large fiber by deep tendon reflex, ankle jerk, knee jerk, vibration perception, and 10 gram monofilament. Protective sensation we can detect from 10 gram monofilament. These are the few simple gadgets. All are present in our clinic. This is tuning fork. This is monofilament. Here this is hammer and pin. This is biothesiometer that detects the vibration perception. So vasculopathy detection, simple palpation of peripheral pulses, dorsalis pedis artery, posterior tibial artery, and this is hand Doppler that can measure the systolic blood pressure in the ankle and of course in the brachium. And it can give a ratio AB index. Examination of footwear is very important because impression in the insole and wearing out of outsole points towards high pressure area. We can see here in this footwear. So ask your patient not to put off his shoes outside your chamber. Ask him to come with shoes. You must see the ground surface of the shoe, sole of the shoe. That is very important because it can point to a high pressure area. An ideal footwear should have a rigid outsole, soft insole, roomy toe box, wide mouth, extra depth of shoes with a counter. And you must discourage Hawaii chappal and normal chappal and ill-fitting shoes to a diabetic patient. Here we can see the result of the continuous friction that causes this foot lesion, and that may lead to amputation if proper care not taken. Now coming to the management part, it is a teamwork. We need a multidisciplinary approach. Physician, diabetologist has a key role to play. Other members of team like surgeons, nutritionists, diabetic nurse, foot care worker, diabetic educator, diabetic cobbler, all are important for salvaging of a diabetic foot. But my request to all physicians sitting here, everyone sitting here, ki diabetes a diabetic foot. Proper workup of diabetic patient is essential to establish neuropathy or vasculopathy. Tight metabolic control is a rule, that is an essential factor. Principles of management remains same globally. These are the 4 basic principles of management of diabetic foot. Good metabolic control, appropriate antibiotics, extensive debridement, offloading. These are, it is non-limb threatening or life threatening. If it is uninfected or mildly infected. In mildly infected cases, there may be signs of inflammation and infection is limited. So this category of patient, physician can take and he can treat. But in limb threatening condition where infection is present but there is no systemic involvement, patient is metabolically stable, this group of patient also can be taken by a physician, but once with infection there is metabolic instability and systemic involvement, it is a life-threatening condition, and in those conditions he must be managed with the help of surgeon by doing indoor admission. So these are few practical things for non-limb threatening condition like callosity. Give empirical antibiotics. In all cases, we must give proper foot care advice and proper footwear advice. In limb renal status, before the result of culture, sensitivity comes, and here are few combination of antibiotic that we prefer in limb threatening and life threatening condition, but always remember the final choice of antibiotics depends on the results of culture sensitivity, and we should take culture from deep tissue, from deep curettage. That is very important. Offloading is very important for ulcer healing. It is defined as any measure to reduce abnormal pressure point to promote healing or prevent recurrence of diabetic foot ulcer. Debridement of hyperkeratotic and callous skin surrounding of the ulcer or woundage is the first step of offloading, and my co-speaker will give detail of offloading. And I'll just show you few slides of few things. This is the plate, this is crutches, this is shoes, all offloading devices. This is total context cast, Roland TCC system, removable boots. This is ortho wedge, post-op shoes, crow boots, or are offloading devices. How they take care of their feet. We can display posters like this in our clinic. And finally, to conclude, prevention is the first and last weapon for the management of and care of the stamp. So again, a preventive strategy, so that the journey begins with prevention and ends with progression. We must take care of a fit of our diabetic patient. Thank you very much.
To talk on management of diabetic foot surgeon's perspective, we have got leading surgeon of Bihar, Dr. Sitaram Singh. Sir, kindly come to the dais, and I will ask chairpersons to kindly introduce him. And chairperson for this session will be Dr. Nirmal Singh, Dr. Praveen Kumar, Dr. Kameshwar. Kindly come to the dais. And I will request chairpersons to kindly introduce our scholar.
Good evening, seniors and colleagues. May I request Dr. Sitaram Singh. He is a renowned surgeon of Sitamarhi and president of ASI Bihar. His topic is management of diabetic foot surgeon perspective. Dr. Sitaram Singh sir, please come on. Yes. आइए ना सर. अच्छा
Respected chairpersons, my dear friends, ladies and gentlemen, good evening everyone. First of all, I am thankful to the organizers, especially Dr. Sudhir ji, to giving me this opportunity to stand here. Really, I feel honored and I am humbled too. Today, this evening, we are going to discuss about the diabetic foot. The disease. The diabetes is a disease which affects all part of the body from head to toes. And today I am asked to deal with the toes, that is diabetic foot. Diabetes mellitus foot is a global burden on healthcare system. 15 to 20% risk in the diabetic foot ulcer. About 70% of the non-traumatic lower limb amputation are due to diabetes, and 85% of the amputation are preventable. Unfortunately, with surgeon, we see the advanced disease. A limb at a risk means a life at stake. A diabetic patient that has potential risk of pathogenic consequences, including infection, ulceration, and or destruction of soft tissue. This condition is associated with neurological abnormality, various degree of peripheral vascular disease, and or metabolic complications of diabetes in lower limb. Many risk factors already have been discussed by the Modi. Now there is many guidelines for a screening of the diabetes. So many screening guidelines are there in International Working Group on Diabetic Foot, Wi-Fi, SIN band. Most acceptable is IWGDF 2023. According to this, a diabetic patient should be screened before he develops the symptom. So if the patient you have got no loss of protective sensation, no peripheral arterial disease, in that case it is very low incidence of ulcer, they are categorized at 0. They should see the doctor once in a year. If there is a loss of protective sensation, also there is a history of peripheral arterial disease, they may develop ulcer, but chances are low. They are kept in the category 1. They should see the doctor every 6 to 12 months in a year. If there is a loss of protective sensation or peripheral arterial disease with one more complication like history of amputation, minor or major, or end stage of renal disease, they should see the doctor on the natural history, Amy, Edmond, and Foster classification. According to this, if there is no normal skin, it is a stage 1. If there is grade 0, when the skin is intact. When there is superficial ulcer, it is grade 1. If there is a dip up to the tendon, ligament, or up to the bone, this is a grade 2. If there is involvement of bone, osteomyelitis, grade 3. If there is gangrene of toes or forefoot, grade 4. And if there is gangrene of the entire foot, it is grade 5. Already etiopathy has been dealt by the previous speaker. Vasculopathy, neuropathy, everything has been discussed by him, so I am skipping this. Common site, already he has shown you how to examine the patients. Now, red flag of surgeons. When the cellulitis is spreading, or there is deep abscess or gas in the tissues, or there is a sign of sepsis or critical limb ischemia. Investigation already we mentioned. Now the principle of management, we should do the metabolic control, you should do the microbiological control, aggressive debridement, wound management, skin closure, and vascular intervention if required. I am going to detail one by one. Already I am discussed. Surgical debridement. This is the cornerstone of treatment. Remove all the necrotic tissue. Repeated sharp debridement often needed. If there is abscess, drain it. If there is a callus, excise it. Sometimes we need minor amputation or major amputation. If there is a compartment syndrome, fasciotomy should be done. At many places, ultrasound-assisted debridement be also done. When in doubt, cut it out. Amputation, this is a surgical reality, but our goal should be limb before the life before the limb. If the limb has got gangrene, you should do the amputation but save the life. And if the limb is not affected but only function is diminished and non-adherent, there are so many available. Hydrogel adds moisture to dry wound or absorbed from wet wound, creating a good healing environment. Non-adherent, these all are available in here. Now also bag therapy is done. vac-assisted closure. It promotes healing by increasing blood flow, removing excess fluid, bacteria, and reducing edema. Also, some places hyperbaric oxygen therapy is done. 100% oxygen is pressurized chamber. It accelerates the healing, reduces the edema, promotes angiogenesis, and fight infection by boosting tissue oxygen level. It reduces the risk of major amputation in Wagner grade 3. There are certain adjunctive therapy. Injection botulinum toxin type A are also injected. They are also in intradermal or subcutaneous around the wound. Some people also use in the gastrocnemius intramuscularly for releasing the pain. What they do, they prevent the release of neurotransmitter acetylcholine at presynaptic level. It attenuates the release of norepinephrine and many neurotransmitters, which inhibits the vasoconstriction and increase blood flow. A few things we should avoid: alcohol, hydrogen peroxide, and povidone iodine. Now, we should think, if the wound does not heal within 4 weeks, we should think beyond the blessing. We should think beyond the bandage. And that is, according to our father of the modern antiseptic surgery, Joseph Lester, skin is the best dressing. So we should put the wound skin. What we do, skin from the another human, that is the cadaver, or from the other species. Now also we can use the skin substitutes. There are artificial skin. Their skins are bioengineered skin substitutes. There are 3 types: biological, synthetic, and biosynthetic. Biological are cellular tissue-based product. These contains living cells, fibroblasts, keratinocytes to activate, promote healing. There are apligraft, dermagraft, amniotic membrane. This is a very encouraging. It is very encouraging because it is very cheap, and it is now manufactured in the India also. There is also National Tissue Bank at Delhi. Many are in India made in the Gurgaon and other places. They can use the human donor tissue or xenograft. Then another is synthetic graft. This is made of silicon, polyurethane, polymer. There may be single layer or maybe double dermoid, dermal and epidermal layer. Now many use are biosynthetic. They combine the synthetic polymer with biological matrix like Integra. This contains collagen, chondroitin 6 sulfate, dermal layer with a removable silicon epidermal layer. It is applied after 4 weeks, silicon layer is removed and split signal graft is given. There is matriderm. They have got the collagen elastin dermal matrix made from the bovine skin. There are also allograft, cadaveric, and donated human skin, but they are very costly. These all artificial skin are available in the India: collagen sheet skin, dermal skin, alloderm, bilayered fish skin. This is a flexible matriderm. Now, there are situations when we are very perturbed what to do, like this. When you are seeing the rocker bottom deformity, as the Modi ji has mentioned about the charcot foot. What is charcot foot? There are 2 theories. One theory is that it is a neurotraumatic. There is a decreased sensation and there is a repeated trauma. So joint and bones become collapse. Another theory is that there is a neurovascular. The increased blood flow, increased osteoclastic activity, something aching for appearance are very mistaken for the infection. Injury may have. Now it is essential to exclude the infection because it looks red, swollen, hot. When the diagnosis is difficult, we can diagnose it. Now management, rest, ideally best rest or use of non-weight bearing crutches. Alternatively, the foot can be mobilized in a weight molded total contact plaster, which is initially not weight bearing. Immobilization is continued until the bone repair is usually in 2 to 3 months. Long-term management. Now this situation, ischemic foot, this is also very difficult to treat. What to do? Doppler studies to measure the pressure. We must measure the systolic pressure at the ankle and brachial. If it is ABI is less than 1, up 1 it is normal. If more less than 0.9 it indicates the ischemia. If it is less than 0.6 indicates severe ischemia. When pulse are absent indicating ischemia, foot is not warm, lesions are on the margins of the foot and the tips of the toes. So what should done? Arterial imaging by technique includes duplex scanning. In this scan, both can be done. We can see the soft tissue, any abscess, and also we can see the blood flow in the arteries. MRI, conventional angiography. Now this is a characteristic of ischemic foot. Luteal artery. So we can do this. A few minutes, please. Please. Common loading methods are total contact class. This should be used according to the need. So surgeon's role in prevention, early referral, patient education, early reporting, if the blisters are callous, foot care advice, proper footwear, regular follow-up. Now take home message, diabetic foot is surgical emergency. Saving limb through science, skill and teamwork. Early detection, timely intervention will help in salvaging limb. Early debridement save life and limb. Multidisciplinary approach essential. Prevention is the best treatment. Thank you so much for patience here.
Thank you, Dr. Sitaram sir, for such a nice presentation. Audience, please ask the questions.
First, big congratulations to both the speaker. Very nice deliberation. One thing, Dr. Modi, because this is a macrovascular complication, so would you like to have preventive statin and disprin in these patients? And second thing, this is most neglected. We as a physician or diabetologist and patient also. So most time what we get, the patients having non-healing ulcer for most of the time. Even if the glycemic control is very nice, still there. So do you have personal experience of hyperbaric oxygen? Dr. Sitaram Singh has put it.
It is applied to all diabetic foot disease. Number one is good metabolic control that includes sugar control, lipid control, blood pressure, that has some role, that is GLP-1 analogs, because it was seen the chances of this diabetic foot disease is reduced. With SGLT2 one analog has a role, chances of foot disease are less. And next part, use of hyperbaric oxygen for treatment. We don't have any personal experience, but hyperbaric oxygen is very good choice because that you can adopt in your home also. There is devices that give you hyperbaric oxygen and results are good.
So particular part or whole body?
No. Particular wound. Good oxygenation. That is the only thing that increases oxygenation. Sir, any comment?
Very tough to manage diabetic ulcer.
Our aim is that there should be a increase in the vascularity. So if you give the hyperoxygen, it will increase the vascularity. So it helps in the healing.
Thank you both.
What is your opinion regarding wound healing using lasers, sir? Wound healing using lasers in diabetic foot, sir.
Laser?
Yes, sir, lasers.
I have got no experience about the laser and I have never seen anywhere about this. Some people are saying then if you use the ultrasound, many people are doing ultrasound, they say that non-healing ulcer healed. That is low intensity, low voltage, and they use. I have got no experience, but there are people having also opening the clinic, ultrasound for the non-healing ulcers, they are doing it.
Thank you, sir.
Wonderful session. Thanks to Dr. R.K. Modi and Dr. Sitaram Singh sir, and to the chairpersons. Now I will request the chairpersons to kindly honor our speakers.
We should clear the dais. We can do it. In the meantime, you call another set of chairpersons.
For the next session, we have got a very good speaker and a very active worker of Rssdi, under whose secretaryship we have got a huge number of members, and as I already talked earlier in the day, we were able to do first rural outreach program in Darbhanga, and we got so many talks here thanks to blessings of Professor ANUJ MAHESHWARI. Dr. Vijay Kumar is the next speaker, talking on transforming diabetes treatment, insulin therapy and cutting edge practices. All of us have got the apprehension when to start insulin and what are the, and to chair the session, I request Dr. Atul Kumar, the senior diabetologist and physician of Patna, Dr. Rajiv Sitamarhi, who has worked under Dr. Vijay Kumar for some time in AIMS, I believe, and Dr. Rajesh Kumar, kindly come to the stage to chair the session and introduce our erudite speaker.
Good evening, ladies and gentlemen. It's a nice gathering over here in Sitamarhi, and pranam to all the seniors over here. Without wasting time, I must call Dr. Vijay, a dynamic worker, as Dr. Ashish had told right now. He is the secretary of Rssdi, and he is working day and night for the team Rssdi to get a good grip in Bihar.
Dr. SHAIBAL GUHA sir, senior physicians THAKUR sir, CV Prasad sir, BN Jha sir, and all the transforming diabetes treatment, insulin therapy and cutting edge practice. In next 10 to 12 minutes, I will discuss how the paradigm shift in the management of diabetes in last 10 to 20 years. Earlier we were glucose centric and now we are weight centric. Most of the pathophysiology of diabetes has been established that it is due to obesity or obesity related problems, and all the complications of diabetes that also usually now weight centric rather than glucose centric. Of course, glucotoxicity plays a role, but now the paradigm shift in the management of diabetes is glucose centric rather weight centric. This is the natural history. We must encounter this slide so many times. This slide emphasizes that pre-diabetes is the right time to start management of diabetes, because once diabetes is established, all the microvascular and macrovascular complications usually starts settling in. So pre-diabetes is the right time, and we physicians, we surgeons, then increase glucagon secretions, single daily dosing, that will be better, reduce the prevalence of hypoglycemic agents, ensure usage of oral agents without avoiding injectable as long as possible. Avoiding injectable as long as possible. There are so many drugs in our armamentarium. I am not going to enumerate, or I am not going to the detail. We all know all the drugs, their usage, their dosage and their indications, and when to start or when not to start. Their efficacy, we also all know. As far as the efficacy is concerned, biguanides and sulfonylurea, they usually reduce A1C by 1.5. And insulin is the most efficient, reducing the A1C by more than 2.5. So this is the classical algorithm. We should start from the monotherapy, then we should switch over to the dual therapy or triple therapy, and when not controlled, then insulin therapy as well. But again, metformin is the pillar drug and already adopted by ASD, ADA, and we have to be PPP4 inhibitors are not. P1 analogs GLP-1 analogs or GLP-based therapy, either DPP-4 inhibitors or GLP-1 agonist, their analogs are quite effective, like exenatide, liraglutide, dulaglutide, and nowadays some oral semaglutide and dual agonist also, tirzepatide. Some are blocking agents, rather DPP-4 inhibitors, they are also quite good and they are second line add-on agent. Their summary of mechanism of action we all know, but to summarize, it decreases food intake and decreases appetite, so increases weight loss and weight centric, this is the weight centric drug. Then gliptins, they are safest drug to use, moderate in potency, and official second line medication after metformin in the affordable group of patients. Repaglinide, netaglinide, these are also GLP-1 group drugs. Useful situations are elderly. It should be avoided in thyroid cell tumors, obstruction, genital fungal infection, urinary tract infection. We have to titrate the antihypertensives also because they have some. We have to titrate the antihypertensives also because they have some sort of antihypertensive effect also. There are certain additional benefits of SGLT2 inhibitors like low risk of hypoglycemia, compatible with other diabetes medications, and consistent small decrease in systolic blood pressure also. So usually we have to revise the dose of antihypertensive medications as well. There are certain limitations: increased risk of genital and urinary infections, risk of dehydration sometimes because in some patients due to glucosuria some sort of dehydration is also being noted. So determinants of OAD usage are body mass index. If it is more than 22, then we can use metformin and gliptins. For presence of GI symptoms, we can use gliptins or glitazones. For renal dysfunction, we can use glitazones. For aging or for those who are vulnerable to hypoglycemia, meglitinides can be used. For hepatic dysfunction, again netiglinide is the drug of choice. And for compliance, gliptins and glitazones are safe. Cost effectiveness, again metformin and sulfonylurea. Coming to the milestone from the OHA to insulin, there are so many developments in insulin. Usually nowadays oral or buccal insulin, nasal insulin, subcutaneous route is the preferred route. Transdermal also coming, inhaled insulin, and intraperitoneal or intraportal insulin. Now what are the indications? Type 1 diabetes, pancreatic diabetes, and gestational diabetes. These are the compelling indications. But when should we use insulin in type 2 diabetes? Because in progressive years there is beta cell failure, and therefore type 2 diabetes not controlled with maximal dosage of oral hypoglycemic agents, or type 2 diabetes during periods of physiological stress, surgery or infection. Pre-gestational diabetes, use of parenteral nutrition or high calorie supplements, in those cases also we use. Then diabetic ketoacidosis is of course the indication for insulin, and sometimes to reduce the progressive complications we need insulin therapy. Chronic renal failure again is an indication for insulin usage. There are different types of insulin: short acting, intermediate acting, pre-mixed, and there are analogs: rapid acting, long acting, ultra long acting, ultra short acting. Then there are certain delivery devices like infusion pumps also. So pre-mixed insulin, usually they are in 30-70, 50-50 we use. Usual starting dose is 0.2 to 0.3 unit per kg. Dose adjustments are usually required. Fasting sugar depends on the night dose of insulin, so dose adjustments are required. Advantages are lesser injections and pen devices are also available, but there are certain disadvantages like strict meal pattern or nocturnal hypoglycemia. A split mix pattern are available. Advantages are less chances of hypoglycemia, but more patient education is required. Bedtime long-acting insulin can also be used. Advantage is once daily dosing, but disadvantage is may need pre-meal bolus. Then bedtime long-acting insulin, it is a single daily dosing, suitable for only less than 15% of patients. Basal bolus regime is also preferred regime, Then came insulin pump therapy, also called continuous subcutaneous insulin infusion, to stimulate endogenous or to simulate endogenous insulin secretion. They are usually being used. So nowadays we are entering in the era of artificial pancreas. The newer insulin pumps are lightweight, portable. They are usually integrated with CGM and they are usually aligned with the artificial pancreas. There are certain indications, there are certain classes of automated insulin deliveries. This is the insulin delivery devices, and who is the ideal candidate for type 1 and type 2. There are different indications of insulin pump therapy. I am not going into the detail due to paucity of time. Then there are certain classical considerations for insulin pump therapies. In nutshell, advantages are ability to more closely approximate physiological insulin, ability to administer very small dose, flexibility in insulin dosing. But disadvantages are high cost, labor intensive, and site changes every 2 to 3 days. There are certain complications of infusion set problems, pump malfunction, or site infection and site reaction. So to conclude, recent developments with regard to insulin analogs and GLP-1 analog has made significant impact on treatment of diabetic subjects, and conventional insulin remain mainstay of therapy in Indian context in the management of diabetic subjects requiring parenteral therapy. The AI of diabetes is A1C, blood pressure, creatinine, diet and drugs, exercise, food and finances, hypoglycemia, and glucose monitoring besides insulin and immunization. Thank you for patience hearing.
Thank you, Vijay, for your nice and crisp, lucid presentation.
Thank you, sir.
You have taken a very vast topic in certain time, small time. House is open for the question, if it's there.
Thank you, sir.
So, we are closing the session and the second session. Sir,
sure, sir.
Please.
Sir. Sir, there are 2 or 3 multicentric trials going on, but we have to wait for the results of those multicentric trials. Till date, there is no data regarding the safety, but there are so many 2 or 3 multicentric trials are going on. Let us wait for the results of those multicentric trials. No, sir. Thank you, sir.
Sudhir, sir. So we are closing the session, and second session will start.
Thank you, chairpersons, for chairing this session. May I now request you to come down below the in front of the dais to receive your mementos, and please give the memento to speaker Dr. Vijay. In the meantime, may I call the chairpersons of the next session, Dr. M. Thakur sir, Dr. Major B.N. Jha sir, Dr. C.V. Prasad sir, and Dr. Manish Kumar Prasad. Manish is not here, right? B.N. Jha sir, Dr. C.V. Prasad. Sir. The speaker for this session is none other than Dr. Sudhir Chandra Jha. Obviously, he doesn't need any introduction. He is the host. But as is customary, we should introduce the speaker. And Sudhir sir is a retired professor of medicine from Darbhanga Medical College, and he is one of those retired professors of medicine who are always involved with academics and always enthused about academic work. And he is always an optimist academic, and we keeps on inspiring the younger generation to get involved with different academical activities. And he loves to speak on some of this, on topics like exercise in diabetes, which is his favorite topic, and chronotherapy is another his favorite topic. So he likes to indulge in this offbeat topics. So over to you, sir. We are expecting an interesting talk from you. May I request the chairpersons to invite the speakers?
Please come. We have got very much details of Dr. S.C. He is going to, he is very fit, he is going to describe, explain about exercise in type 2 diabetes, its role.
Respected chairpersons, esteemed colleagues, and most honorable National President Rssdi, Professor ANUJ Maheshwari. This is the diabetic triad. You need these three things: diet, exercise, medications, and of course under monitoring. But exercise is a $1 billion drug that seldom gets prescribed. Physical activity, when it is structured to achieve a metabolic goal, that is known as exercise. Any physical activity is important, but structured has got an aim. What is the basic physiology during exercise? During first few minutes of exercise, glycogen in the muscles are broken down. After 5 to 10 minutes, muscle glycogen breakdown decreases and hepatic glycogenolysis takes over. At 20 minutes or more, adipose tissue breakdown comes into the picture. So if you want to lose your weight, this is important to have a sustained exercise beyond 20 minutes also. Metabolic equivalent is defined as the amount of oxygen consumed while sitting at rest and is equal to 3.5 ml oxygen per kg body weight per minute. Energy expenditure during test is 1 MET, and it is then calculated like this. There are many mobile apps where you can calculate that. Less than 3 MET is the light exercise, 3 to 6 MET is moderate, and above 6 is the vigorous exercise. But in clinical practice, we can do on the basis of heart rate. Maximum heart rate is calculated first. You reduce your age from 220, that is the maximal heart rate. Low intensity is 40 to 50% of maximal heart rate, when the person can talk or sing during exercise without getting breathless. Moderate intensity, 50 to 70%. Patient can chat but cannot sing comfortably. And high intensity is 70 to 85% of maximal heart rate. Patient can barely talk. Now, role of physical activity, I will not waste my time in elaborating the benefits it has. It has got the wonderful, be it A1C, insulin requirement, body weight, coronary risk factor, body composition, overall cardiovascular, overall this cardiac mortality. Wonderful results. But gone were the days when you used to say walk for 1 hour, everything is okay. Is walking alone okay? No. It has to be supplemented with the resistance exercise. That is very important to remember. These two exercises are very important, and better if you can combine this with the flexibility and balance exercises. These are the different calories. You can get it from Google. I am not going into detail for the paucity of time. This is the calories burnt in different exercises. And aerobic exercise is with oxygen, which means that breathing controls the amount of oxygen that makes it to the muscles to help them burn fuel more and more. And examples are walking, cycling, jogging, and swimming. Now, benefits of aerobic exercise. All this aerobic and anaerobic exercises have got the similar impact, but in the mitochondrial density, it has got more this thing. And maybe for the cardiac results and substantial reduction in cardiovascular risk, this is very important. Now, anaerobic exercise or resistance exercise, short, fast, high intensity exercises that don't make your body use oxygen like it does for the cardio or the aerobic activities. Instead, anaerobic activities break down glucose that is already in your muscles for a form of energy. Examples are exercise with the free weights, weight machines, body weight exercise, dand baithak, what you call in Hindi, and elastic resistance exercises. Benefits of resistance exercises, they are more effective in improving the function of GLUT4. What is GLUT4? Glucose transporter 4, which is so important in carrying glucose inside the cell and getting it metabolized. Muscle hypertrophy is important. That imparts the improved strength and medical physical function. Better tolerability, mental health is better. Bone marrow density is improving. And today we are talking about the sarcopenia, loss of muscle loss. After 30 years of age, every year we are losing 3 to 8% of our muscle mass. And if we can slow down that, that is of immense value. Ours is a sarcopenic country. Most of us are having this. Now, this is very important, and most important slide is this. Insulin isn't required for glucose to enter into cell when we are exercising. So what is known is that this pathway is not affected by people with type 2 diabetes. This is a form of non-insulin dependent glucose uptake. This is also known as the contraction mediated glucose uptake. So the effects of acute exercise, just one exercise one person does, and what is the result? There is increased immunosurveillance, frequent mobilization and distribution of effector lymphocyte. Just in response to one bout of exercise, literally billions of lymphocytes are mobilized, which are primed and looking for a fight. Your whole army is there to fight the intruders. Flexibility exercises improve a range of motion around joints, and balance exercises are so beneficial, particularly in old age, to prevent falls. Activities like Tai Chi and yoga combine flexibility, balance and resistance activities. Recommendations for this slide is very important. Recommendations for reduced sedentary time. Everybody is talking about exercise, but what about the non-exercise time? Even during the non-exercise time, prolonged sitting is equivalent to smoking. After 25 to 30 minutes of sedentary behavior, you should have at least 3 to 5 minutes of aerobic exercise. Now, pre-exercise assessment is one size doesn't fit all. When we go to tailor, we have got the different. We are ordering for the suit, but one size is not enough. So every patient is different from other patient. Patient may be having neuropathy, retinopathy, coronary artery disease, peripheral artery disease. How much exercise to be done? Just remember the FIT principle, F-I-T-T. F is frequency, exercising 4 to 6 times a week. Intensity, 30 to 40 minutes of exercise at 50 to 60% of target heart rate. And type, safe exercises are recommended. This is very important thing because it can have the deleterious effect also. Time, morning time is ideal. Recently few evidences are there which suggest that it could be better if you can do in the afternoon. But in the busy schedule of today, whatever time you get, you do exercise, that is a must. Now aerobic exercise is very important. Warm up and cool down, we know about it, but it is seldom done properly. This is very important. Resistance exercise, 6 to 8 exercises targeting major muscle group is important, and gradually increase resistance until we can perform 3 sets of 8 to 12 repetitions for each exercise within 1 to 2 minutes of rest between them. When beginning resistance exercises, it is best to receive initial instruction and periodic supervision by the qualified person. Interval exercise training is very important. Few minutes of intense exercise and few minutes of rest in between. Then there is high intensity interval training, what many people are talking nowadays. High intensity interval training is a form of training, a CV exercise strategy, alternating intense bursts of high intensity exercise with medium intensity exercise for recovery. Here during the rest, we are not coming down to the zero rest, we are coming down to the moderate form of exercise. And there is increase in mitochondrial content, more oxidative capacity of muscle, slows down sarcopenia, and more CV fitness and better mental function. ADA recommendation is that 150-minute or more of moderate to vigorous intensity exercise spread over at least 3 days a week with no more than 2 consecutive days in between. Shorter version 75-minute can be done if the exercise is of vigorous or high intensity type. And adults with exercise should have 2 to 3 sessions per week of resistance exercise on non-consecutive days. You have to allow 1 day for the rest of the muscle. Type 1 diabetes is not the subject of my talk, but a word or two about this. Insulin resistance here is not a major issue, but variable glucose control is. And there is more important challenge to avoid hypoglycemia. Decrease insulin dose prior to exercise to avoid that. Short session, glucose monitoring is important, and frequent carb feeds should be available to combat it. Recommendation for gestational exercise. Already we had a dedicated session. Here one thing is that a pregnant lady should be active, but she should not be allowed to have a fall. It should not be a brisk one. Saving pregnancy, saving mother and fetus, that is important. And postprandial exercise was also talked during that session, that if the mostly sometimes the postprandial glucose is very high, so 30 minutes after a food, if one takes 20 minutes of exercise, that is of major benefits to the person. So in peripheral autonomic neuropathy, treadmill, prolonged walking, jogging and step exercises are avoided. Recommended are not wearing exercise, swimming, bicycling, chair and arm exercise. Nephropathy also, we have to avoid the high intensity exercise. Diabetic retinopathy, contraindicated because of the risk of hemorrhage. Strenuous activity, pounding or jarring, such as weightlifting, jogging, high impact aerobics. And what is recommended is low impact cardiovascular conditioning, such as swimming, walking, low impact aerobics, stationary cycling, endurance exercise. Tips are always carry an identification card with you, particularly when you are in gym, because some problem can always be there. Check your feet, which Ravi so importantly talked about. Choose good footwear, light clothing, drink a lot of water, and hypoglycemia at all costs should be avoided. So high glycemic index carbohydrate, glucose preferably should be available. Snacking should be there to this thing. Physical activity lowers blood glucose. This is a wonderful picture. The red one is before exercise, the yellow one is after exercise 1 year later, how the glucose tolerance curve has improved. Now there are celebrities with DM, diabetes mellitus: Thomas Alva Edison, Mario Puzo, Kamal Hassan, Sonal Kapoor, Nick Jonas, Tom Hanks, and many more. List is there. This is Billie Jean King, many times tennis champion despite diabetes. Wasim Akram is one of my favorites, not because of any political reason, but because of his sporting reason. Despite having diabetes type 1, he was a champion. He was the best outswing bowler in the world. But we always offer some excuses for avoiding exercise. I simply don't have the time. Cardio is so boring. I will never get six-pack, so why bother? Six-pack is not important, your life is. I just don't like working out. I feel selfish, something like this. Now, in a 15-minute intense workout is only 1% of your day. A 30-minute workout is only just 2% of your day. A 60-minute workout is only 4% of your day. So friends, colleagues, no excuses, simply no excuses. You don't have any alternative, but go for it. So take home message is, exercise is an invaluable drug which is seldom used. All diabetics needs to be motivated and educated about planning out the exercise and to exercise as a way of life since early school days. This, along with dietary education, may help us fight the tsunami of diabetes mellitus. The stalwarts, our national president is here. I always urge the highest officials in this regard that you put pressure on the government to make exercise an integral part of the school curriculum and to spread the awareness if we want to lessen the socio-economic burden and remove our tag of diabetes capital. Just imagine if the diabetes is having complications, if diabetic food develops, what is the expenditure the patient is going to sustain? Just having a CKD means his whole savings are destroyed. So it is better to rise earlier, better to fight the dreaded disease at the outset, and what can be better than exercise which is so inexpensive. Thank you for the patient hearing.
So very nice and elegant talk, Dr. Jha. Because we are running short of time, so I will hardly allow in question. So any doubt, any queries, one can ask Dr. Jha personally. So one thing I want to spread, Dr. B. Mohan said, the famous diabetologist of India, there was 17% diabetic in that area of Chennai, some part. And with the government help of the society, they put 2-3 park. The incidence from 17% came down to 10%. So that is good lesson. Even simply by making park, the incidence of diabetes came down by 7%. So again, thanks a lot for you.
Thank you. Thank you.
I just wanted to add one thing. The people who are of long time sitting duty or habit, they can do soleus push-up. That is just like walking or running. So this is a peripheral heart, you can say. You can have soleus push-up 10 to 15 times at the interval of every 3 or 4 hours. That is a option for the sedentary people.
Soleus is a very small muscle behind gastrocnemius, and it starts utilizing glucose right at the outset. In my first graph, I said few minutes muscle glycogen, then hepatic glycogenolysis, then adipose tissue. And here is one tissue which starts consuming glucose right at the outset. And the process is very simple. While sitting, you raise your heel up and down, up and down, up and down. While seeing the patient, you can also do that.
So with this, I will close the session and hand over to our lecturer.
So may I request our chairpersons to felicitate our speaker to proceed ahead. बीके सर आ जाइए, आप भी आ जाइए। बीके सर, आ जाइए। सवाल सर, फ्रेम में आ जाइए। सवाल सर। Now may I invite so to the chairpersons also. आ जाइए बीके सर, थोड़ा एक्सरसाइज भी होगा। लगातार बैठना ठीक नहीं है, लगातार बैठना ठीक नहीं है। ठाकुर सर, बीएन झा सर। So thank you, chairpersons and speakers. Kindly settle down. So to proceed ahead, may I invite for the last talk of this session, may I invite the chairpersons for this session, our National Executive Committee member Dr. B.K. Singh sir, kindly come on the dais to chair the session. Chairman-elect Dr. SHAIBAL GUHA sir and Dr. Shree sir to chair the session and introduce our National President and invite as the speaker. Sir. Over to you, chairperson.
It is my proud privilege to introduce my friend and President Rssdi, Dr. ANUJ MAHESHWARI, whose creativity, focus and passion are so unmatchable that he has risen to the topmost force in Rssdi. And I want to emphasize one point. I have never seen him tired. And one thing which he said, for the cause of diabetes, I can travel to the remotest corner of India. A big hand for him, big hand.
Thank you, thank you.
And this topic, circadian misalignment and global obesity trends, is a very relevant topic today, and no person can be better than him to deliberate on this.
Thank you. Thank you, Dr. Shree. Thank you, Dr. B.K. Singh. Thank you, Vijay. And all those who are, Dr. SHAIBAL GUHA and Sudha Madam, whom I could met yesterday only. So it's really, I am very much overwhelmed of the joy, as well as feeling proud, privileged to be at the land of Mata Sita. And truly said by Dr. Shree, this is a journey from Jai Shri Ram to Jai Siya Ram. We have been at Lucknow. Lucknow is also a city which have been in the name of Lakshmanji, and Lakhan is still in its name. It is very small distance from the land of Ram and Sita at Ayodhya. And again, I could be able to, at this pious land which belongs to Mata Sita, and really feeling myself lucky enough that I could be able to be there. And I also say this with pride that I am the only Rssdi president who has visited Bihar so many times and explored the Bihar. This much of the depth, like I am at the Sitamarhi, I am in the Aurangabad, I have been at the Darbhanga and Bhagalpur. So I think Muzaffarpur, I have organized 2-3 meetings. So it's not only the Patna. Most of the people comes to Patna and they say that I have been in the Bihar. So I have explored the Bihar deeply, even at the Gaya also once. So this is really, I feel this pride, and this is really a proud privilege. Today's program has been so excellently made, Dr. Shree made, or whosoever has made, that we have started with the conventional topic to the unconventional out-of-box topic. We started with the conventional debate of whether the cardiovascular diabetes is having its impact on the CAD or not, and then we could reach to the women diabetes, or not in the diabetes in pregnancy. It was not truly in the women in diabetes, in fact gestational diabetes only. That was only one part of the diabetes what we could cover up. Just diabetes in pregnancy can be divided into the 3 parts: type 1, type 2, gestational. But we could cover only one part. But I have been much appreciating that exceptionally high level of the talks has been presented by all the panelists, those who were here. And then we could see the very out of the box topic on the exercise what Dr. Shree has taken himself. Vijay has taken a very nice talk. But again, my complaint has remained most of the time that we discussed mostly the ADA ESD guidelines. Very few people, I never found today anybody could take any Rssdi guidelines name. Nobody. So it is our duty that Rssdi guidelines should reach to each and every corner of the country, because these guidelines are our own guidelines which have been made with the Indian perspective, as it is duty of all Rssdi member. अगर RSSDI के प्लेटफॉर्म पे RSSDI गाइडलाइन नहीं बोली जाएंगी तो कहाँ पे बोली जाएगी? ये दिस इज द प्लेटफॉर्म ऑफ द RSSDI. यहाँ पे हम ADA ESD की गाइडलाइंस के बारे में बात कर रहे हैं. क्यों बात कर रहे हैं भाई? हमें अपनी हम कंपैरिजन तो कर सकते हैं, बट हमें RSSDI की गाइडलाइंस को फ्रंट पे रख करके बात करना है, एंड अगर उसमें कोई कमी है तो उस कमी को दूर करना है. आई वेलकम यू ऑल. इफ़ यू फाइंड एनी प्रॉब्लम, एनी deficiency in the RSSDI guidelines, we are in the phase of revising the RSSDI guidelines. इस समय रिवीजन चल रहा है guidelines का. You can tell us that this thing I do not agree what the RSSDI recommend. If you provide the enough evidence of the RCTs or publications, I am sure that your suggestions would be included in the guidelines. So we want actually the guidelines to be made for the people of India, have been made by the people of India. It should not be that people of America are making the guidelines for the people of India. So let's come over to the topic. Circadian misalignment and global obesity trend. Obesity is increasing day by day. It is not a new thing for all of us. And circadian misalignment, what is the circadian misalignment? Many of the people may not be much accustomed of this topic and of this word, but I shall be telling you what I mean to the circadian misalignment. But before that, I must say that growing crisis, that presently we are having 1 billion obese individuals across the globe. And this is the 2 times increase in the last 50 years across the globe. इंडिया की बात करेंगे तो वो बहुत ज़्यादा है. इंडिया में पिछले 10 साल में 2 गुना हो गए. पूरे वर्ल्ड में हम 50 साल हमें लगा 2 गुना ओबेसिटी होने में, बट हिंदुस्तान में हमें सिर्फ 10 साल लगा. एंड दिस इज बिकॉज ऑफ द मॉडर्न लाइफ स्टाइल विच इज डिसरप्टिंग अवर नेचुरल सर्कैडियन रिदम. 24/7 we have started been working. 24/7 we are keep on awake and we are all the time on the move. The modern lifestyles increasingly disrupt our 24 hours biological clocks through shift work, irregular sleep and late night eating, altering metabolism, appetite and energy balance. 8 मिनट से बता रहा है, मेरी पहली स्लाइड है. So I think I have talked non-conventional much. So let's come over to the what is circadian rhythm. Your body's 24 hours internal clock is which is defining and which is governing the circadian rhythm, and this is controlled by a center in your brain that is called as suprachiasmatic nucleus in hypothalamus, which is driven primarily by light, dark, and it's a cycle, like once you are having in the daytime, once you are in the night time, as well as these lights is reaching to the retina, which is having its impact on the optic nerve, and finally the message is going to the suprachiasmatic nucleus. So this is not simply a thing which is being told on the concept. In fact, this is very well scientifically defined and scientifically proven. What happens here? Once these signals in the form of the light comes and goes, it decides our sleep-wake cycle, which gives an idea about the alertness and natural sleep pattern. Once there is a darkness, you are going to sleep. Your brain is in the format of getting slept. Once the light is there, even if you do not want to be in the bed, your body's system wakes you up, gets you above the out of the bed. It also manages the body temperature. Many of the people don't know that our body temperature does not remain same throughout 24 hours. In the morning hours, it is always lesser. In the evening, it is the higher. People comes and say that evening rise fever. Evening rise fever कितना है? 99 degree Fahrenheit. 99 degree Fahrenheit शाम को 6 बजे normal temperature है. It is not a fever. So don't ever think that, because हमें अगर circadian rhythm का पता नहीं है तो हम ये सोचते हैं कि ये fever है. And many of the time patients are wrongly treated. Then comes to the hormonal release. Hormones in our body are also released as per the pattern of circadian timing, its circadian regulation, which is also governed by the light and dark cycles. So how does it happen? Once you are going to sleep, your sleep hormones is increased in your body. What is that? Melatonin. Melatonin is a hormone that induces the sleep. And once you are going to come towards the morning side and that time of get up is coming up, cortisol starts rising. Melatonin starts coming down. And this cortisol rising actually works as an anti-insulin hormone. So once the anti-insulin hormone, once the insulin's action is going down and anti-insulin hormone is taking the actions up, that is the time when your blood glucose is going to be maximum. That's why fasting blood sugar morning में करते हैं, क्योंकि morning में अगर आपका blood sugar normal है, हम ये भी कह सकते थे कि आप 8 घंटे की फास्टिंग दोपहर से शाम तक मान लो तो भी फास्टिंग होगा, पर उसे हम फास्टिंग नहीं मानते. हम कहते हैं फास्टिंग शुड बी डन इन द मॉर्निंग बिकॉज ऑफ दिस कॉर्टिसोल राइज. बिकॉज कॉर्टिसोल राइज होने के साथ में भी अगर ग्लूकोज लेवल नॉर्मल है, एंड वंडरफुल, then it cannot be more than that. Then it comes to the digestion. That also coordinates the nutrient processing and blood pressure, and it also depends upon how does we eat, at what time. After 6 p.m. whatever you are eating, this is increasing your insulin resistance, and that all are going into the storage. And nowadays our youngsters and our most of the population had started eating in the night time. Our youngsters keeps on awake on computer, mobile phone, and they keep on munching and keep on eating throughout the night. That is one of the biggest reason of the obesity in adolescents, youngsters, as well as in our most of the society. हम लोग जब बच्चे थे तो हमारे क्लास में 1 या 2 मोटे बच्चे हुआ करते थे जिनको हम लोग चिढ़ाया करते थे. आज अगर आप उसी सेक्शन या उसी स्कूल में जाएं, then you will find that 90% people are obese, 90% kids are obese, only 5 to 10% kids you will find those who will be of normal of their weight. This is because of this misalignment of the circadian rhythm. So this desynchronization between the internal circadian clock and external environment, that brings this problem. And how does this desynchronization takes place? One is shift working. आज हमारी डे शिफ्ट है, कल नाइट शिफ्ट है, परसों फिर दोपहर की शिफ्ट है, and this is giving us a very difficult adjustment of the light and dark cycle as well as sleep and wake cycle. Then jet lag. Nowadays people are traveling more, traveling from one part of the globe to the another part of the globe, and that is also giving to jet lag. That is well understood, but it does not happen 2 or 3 times in more than 2 or 3 times in a year. But if you are keep having these journeys more frequently, then it also impacts your metabolic system. Late eating, we have already discussed it. Irregular sleep, we have already discussed. Social jet lag. What is social jet lag? Social jet lag is a new terminology, and that terminology is for keep rising with your mobiles and your computer screen for a late night is social jet lag. And this social jet lag is also causing the desynchronization of your biological clock to the external environment. So this has actually increased the global obesity trends, which reached to the up to the level of crisis. 524 million adults were with the obesity in 2010, which has gone up to the 1.13 billion adults with obesity in 2025. 115% का growth obesity में. 115% is grown from 2010, and it is expected to reach 2030. 385 million are having the class 2 obesity, which you can say that BMI is having more than 35. 145% is the growth in BMI more than 35 by 2030 is expected. This is the regional obesity increase. Highest in the Western Pacific. Western Pacific में कौन-कौन से देश आते हैं? Japan, and it comes to the Vietnam, China. Southeast Asia, you all know that we are living in the Southeast Asia. Then it comes to the Mediterranean, then it comes to the Africa, America and Europe. So we are more closer to the Western Pacific. But we follow the guidelines of those who are at the lowest level of the problem, what the problem we are facing. We are facing diabetes, we are facing obesity, we are facing hypertension. We should look for the Japan and China, how they are managing their diabetes and hypertension, but we look towards America and Europe, those who are having much lesser problem than us. It is simply just, still we are living in the colonial era. Mechanisms linking misalignment to the obesity. There are 2 important hormones which are important for the misalignment linking with the obesity. One is hormone which is responsible for the hungerness, that is ghrelin hormone, and another is the hormone which is responsible for satiety, that is the leptin. Once the leptin level rises, your satiety level goes up. Means you are getting satisfied with a small amount of the eating. Once the ghrelin is getting higher, means you are not getting satisfied after even Dr. Nisha, please. After even you are not, after even you have eaten lot of food, still you are not getting satisfied. Mummy ka phone hai. So still you are not getting satisfied. So this is the problem because of what this disruption is taking place, first through the hormones, second through the insulin resistance, where the reduced glucose tolerance at night, I have already said about that, altered energy expenditure, lower nighttime metabolic rate, and in those times we are using more and more eating materials which are getting collected in our body. More of the cravings, especially for the high calorie food, and this craving is also vicious, which is जितना आप खाते जाते हैं उतनी आपकी craving बढ़ती जाती है. अगर आप के सामने मिठाई रखी हुई है और आप नहीं खाएं तो वो आपकी क्रेविंग नहीं है, पर अगर आपने एक पीस खा लिया तो दूसरा पीस खाने की भी इच्छा होती है, एक रसगुल्ला खाया तो दूसरे रसगुल्ले की भी इच्छा होती है, तीसरे की भी इच्छा. This is called the craving, which is coming upon the vicious cycle. Sleep deprivation, which is because of the high level of the cortisol, and it also promotes the fat storage. Sleep deprivation induces the cortisol rise, and cortisol rise induces the fat storage. Metabolic dysregulation is coming up through the clock gene desynchronization. I have already explained the mechanism of that. Then feeding, fasting, uncoupling, that has also been discussed here. Most of the time we say that we are doing the religious fasting, but in religious fasting we are feeding more, fasting less. May it be Ramadan fasting, may it be Navratra fasting. In both the fasting, our feasting is more, fasting is much lesser. Nutrient sensor distribution, altered oscillations of the metabolic genes and nutrient sensors, that also makes our system more more inclined towards the obesity when it stops sensing that desire of the food is over. Once our desire of the food is not required there, the brain should give a signal कि अभी खाने की ज़रूरत नहीं है, अब आप खाना बंद कर दीजिए. But these signals are becoming blunt, stopped coming up, because of what? We don't stop eating and we keep on continue with the eating. Impaired glucose tolerance and insulin sensitivity is coming up through this, and this is actually giving rise to the more and more collection of the fat. Dysregulation of the lipid metabolism pathway is one of the important mechanism which is coming up through the insulin resistance. Once the insulin resistance goes high, more and more deposition of the fatty material would be there. Appetite hormone dysregulation, as we discussed, that leptin and ghrelin response. And one more important is here, impaired postprandial suppression after the meal, that is brought by the peptide YY. So blunted appetite hormone responses promote the overconsumption, creating positive energy balance and weight gain trajectory. Cortisol and HP axis regulation. Normal diurnal patterns becomes inverted in this desynchronization process whenever the circadian misalignment comes up. So what happens, that inversion of the normal diurnal pattern says that cortisol rise should be in the morning hours at around 4 o'clock to 6-7 o'clock. इसीलिए कहते थे कि उस समय अगर आप उठ करके पढ़ाई करते हैं तो दैट गोज टू द ब्रेन एंड जल्दी याद होता है, जल्दी या सुबह पीपल यूज टू डू द प्रेयर्स, पीपल यूज टू डू द various important works in the morning hours because the cortisol level remains very high at that time. But now the things has been changed. हमने अपने खुद के एक्शन से अपने बॉडी को इस तरीके से चेंज किया कि cortisol level now started keeping on rise in the evening. Elevated night time cortisol promotes the visceral fat accumulation. अब वो हमने जब सारी अपनी एक्टिविटीज़ रात के समय पे फोकस कर दी तो सारा cortisol रात में रिलीज हो रहा है. And what is more dangerous things is happening. Once you go to sleep, your blood pressure comes down. That is called as dipping in the blood pressure. And this dipping of blood pressure does not come because of your sleeping. It comes because cortisol level is going down. And once it starts rising, your blood pressure also starts going up. In the morning times, it remains at the highest of the throughout 24 hours. But in cortisol rise in evening or in the night or you before sleep does not allow your blood pressure to come down, and it remains on the higher side even when you are sleeping. And that is one of the important reason of death in bed, important reason of the midnight myocardial infarction and even strokes most of the time that happens. So chronic stress signaling that increases the hepatic glucose output. Whenever we are not eating, who is keeping us alive? The liver is keeping us alive. जब हम कुछ नहीं खा रहे हैं तो हमारे पास ग्लूकोज की सप्लाई कहाँ से आती है? लिवर से आती है. Hepatic glucose output is keeping us alive in those time. But once we start eating, that supply used to stop. But once it does not stop, it continues there, and our meal-derived glucose is also coming to us, and it is making us diabetic, reaching us postprandial hyperglycemia up to the sky high most of the time. So synergistic effect with impaired insulin secretion creates a metabolic cascade promoting weight gain and diabetes risk. So here we can have the two different things what we usually face. One is glucose dysregulation and there is the lipid dysregulation. Lipid dysfunction is actually coming up because of the high level of the free fatty acid. That is also the product of the insulin resistance. On the other hand, the product of the insulin resistance which is coming up, the glucose dysregulation, that is the hyperinsulinemia. And hyperinsulinemia together with the hyperglycemia, that happens in the pregnancy also, making us more prone women for the abortion. Elevated fasting glucose level is also responsible and also is the act of the continuous hepatic glucose output. Impaired postprandial glucose also coming up even in the pre-diabetic pattern once the people are suffering with the fatty liver disease. And that's why this is the fatty liver disease which is beginning the diabetes, not the diabetes is causing the fatty liver disease. So after the endothelial dysfunction, whatever the worst possible things happen, that is the fatty deposition, de novo lipogenesis that starts happening in our body. जब हम खाते हैं और उस खाने को इस्तेमाल नहीं करते, तो what happens to that calorie? That calorie goes to the liver and it gets converted into the fat and gets it collected there. So first it gets collected into the glycogen. Once the glycogen storages are full, then it starts getting collected into the lipids, and that is called as de-lipogenesis, de novo lipogenesis. And later on it starts coming to the rest of the body. And that fatty liver degeneration brings down the fatty action on the which helps us in keeping our glucose level normal in the night time when we are not eating. And this keeps on continuing faster and faster because of the effect of the insulin resistance, and we face the crisis of the hyperglycemia. Similarly, we see that reduced peripheral tissue glucose uptake is also associated with that. So this all causes the inflammation and oxidative stress. Systemic inflammation which is coming up with the high inflammatory marker level like IL-6, TNF-alpha, CRP. Oxidative stress is coming up because of the reduced antioxidant defenses. Metabolic endotoxemia, which is driving the visceral adiposity and obesity related inflammation pathways which are having a different inflammatory markers, and this circadian disruption increases the systemic inflammation markers in circadian misaligned individuals, creating a vicious cycle that perpetuates metabolic dysfunction and fat accumulation. So fatty liver disease, already I have discussed this mechanism of the fatty liver disease. Now coming up to the cardiovascular risk in circadian misalignment. Blood pressure and endothelial dysfunction. Elevated blood pressure and endothelial dysfunction through the disrupted vascular tone regulation keeps on coming up regularly with the people, those who are having circadian misalignment. It also alters the vascular tone regulation via circadian nitric oxide pathway. Visceral adiposity is becoming an end product of circadian misalignment, and it is also increasing the cardiovascular risk. Autonomic dysfunction, especially the cardiac autonomic dysfunction, which is responsible for the arrhythmia and sudden death in the midnight, and cardiac autonomic dysregulation is also coming up because of the circadian misalignment. The synergistic effect, combined obesity and circadian disruption, dramatically escalates the cardiovascular mortality risk. Sex-specific metabolic responses. Males and females, they are different. Females are having higher insulin resistance while the men's are having higher endothelial dysfunction. With the same amount of the insulin resistance, men's are having higher endothelial dysfunction. With the same amount of the endothelial dysfunction, women are having higher insulin resistance. Greater lipid dysregulation, estrogen dependent clock gene regulation is also among the women, and that's why we see that women are protected from the cardiovascular disease during their reproductory life. During their life when they are reproducing children and they are active, menstrually active. Different inflammatory response patterns remains with the women. On the other hand, men's are having higher blood pressure elevation as compared to the women, but after menopause, women take over that blood pressure rise from the men, and they have got more hypertensive as compared to the men. Different metabolic vulnerability patterns is also seen with the men as well as distinct cardiovascular risk profile. Time restricted feeding as a therapeutic mechanism has found to be helping us. What is the time restricted feeding? Don't eat anything after the sunset and don't eat before the sunrise. So if you are keeping yourself free from eating in 12 to 14 hours, this will be giving you a kind of the intermittent fasting, which is the time restricted fasting or time restricted feeding also. Sleep insufficiency and obesity risk. Whatever the obesity is there, this is also giving rise to the obstructive sleep apnea. Sleep extension and circadian alignment work together for the optimal metabolic health. Adolescent. Already I have discussed this problem with the adolescent. Biological phase shift is seen. Most of the time we think that in the morning hours we are more efficient to grab the new information and knowledge. But every age group is not having the similar circadian rhythm. What the circadian rhythm is in our adult, the same circadian rhythm is not in the children. So children and adolescents are having the circadian rhythm which is very much different, and it has been seen that those schools are calling their students at 7 AM to 10 AM or 12 AM, they are found that students are having poor grades in their marks as compared to those who are asking their children to come at 10 to 5 AM shift. So this shift is giving rise to poor performance because of those time is the sleeping time, and they are having in their sleeps, and most of the things they are doing in their sleep. You must have observed your kids when they are going to school, आधे नींद में सो रहे होते हैं, आधे जाग रहे होते हैं, and same thing happens when they are going to the school. Occupational circadian misalignment, shift work, already I have discussed this. Clinical interventions for the circadian misalignment can be done by the light therapy. Bright light exposure for the circadian phase adjustment and entrainment could be helpful for making more and more circadian alignment. Sleep hygiene could be a best method for removing circadian misalignment. Meal timing should be brought to the maximum as I discussed with the time restricted meal. Physical activity, one of the most important things which we have forgotten. Dr. S.C. Jha has already given you a prescription of the exercise, and we should all follow that prescription. Exercise at the optimal circadian phase and optimization of the temperature, darkness and noise control while you are sleeping is again very much needed for removing the circadian misalignment, or you keep the circadian alignment. Pharmacological and novel therapeutic approaches like melatonin, clock gene modulators like circadian rhythm should be combined with the pharmacotherapy. Pharmacotherapy may be in the form of the GLP-1 receptor agonist, melatonin. Microbiome interventions are also being worked up upon. Epigenetic monitoring in the form of the BMR1 and clock methylation biomarkers which are being under trial right now. Chronotype based medicine like personalized circadian intervention. Policy and population level strategies, food policy, food labeling and taxation on ultra processed food to reduce availability. Means there should be a food policy. The foods which are carrying high calorie, they should be labeled for their caloric information, as well as they should be taxed higher. Foods which are having high sugar, foods which are having the high salt, they should be having extra salt and sugar tax kind of the thing, which can help the people in using them comparatively less. built environment like urban design promoting the physical activity and access to healthy foods. School start timing, now the government has been much aware about that. Most of the countries has started that school should not be started before 10 a.m. The policies addressing the adolescent circadian biology needs should be according to the school start time. Workplace reform, scheduling the reforms and protection from the shift workers. Shift workers का protection आप कैसे करेंगे? Shift workers, you cannot stop कि आप रात में काम मत करो क्योंकि हमारा भी काम नहीं चलता अगर कोई रात में काम नहीं कर रहा और जो काम कर रहा है उसको भी कुछ पैसे कमाने हैं. So what is the method of that? You can switch on the shift gradually. Like आपने पहले किसी पे बंदे को 8 से 2 का शिफ्ट दिया, फिर उसका शिफ्ट 10 से 5 का किया, फिर उसका शिफ्ट 2 बजे से 8 बजे का किया, फिर उसका शिफ्ट रात का किया. तो इस तरीके से अगर आप शिफ्ट की ग्रेजुअल स्विचिंग करेंगे then it would be less harmful. And health system training in the form of the healthcare provider education, and the healthcare provider should be more trained towards the circadian based obesity management. So these could be the strategies to reduce the misalignment, consistent sleep schedule, maintain regular sleep wake times even at the weekends. वीकेंड है तो इसका मतलब ये नहीं कि लंबा सोना है, और वीकेंड है तो ये नहीं कि उसमें हम इतनी ज़्यादा एक्सरसाइज कर लें कि हम उसको मेंटेन नहीं कर पाएँ. मॉर्निंग लाइट एक्सपोजर, प्रायोरिटाइज ब्राइट लाइट इन द फर्स्ट आवर्स आफ्टर द वेकिंग. Avoid screens and blue light before bedtime. Avoid late night eating. Daylight aligned meals should be with daylight hours. Early exercise, schedule physical activity in morning or early afternoon. Early afternoon means after around 3 p.m. to 5 p.m. if you are doing the exercise. This is very good for your muscles build up and development. So future direction and conclusions could be that circadian misalignment can be addressed through the intervention, appropriate intervention, what I have just suggested. So clinical behavior, policy and chronotherapeutic strategies should be implemented in total together. Guidelines should integrate all these recommendations to avoid the obesity, to reduce the obesity burden. Prevention opportunities must be there. Unprecedented chance to combat obesity epidemic is there once we are applying these prevention opportunities. Thank you very much for your kind listening. कुछ शायद नया मिला होगा.
Excellent talk. I request all of you to give big round of applause to our President, Dr. ANUJ Maheshwari. If you can see that in any universe, everything is in rhythm and everything follows some clock system. So if there is a disruption in that particular or misalignment in that particular with nature, always create problem. And that is the message of ANUJ Maheshwari, that if you use excessive mobile, that means you are deprived of sleep or deprived of anything. That will create a problem that is not harmonious with the nature. So try to follow the nature's rule and adopt the healthy things. Now I invite any questions from the audience. If you want to ask any question.
I think already it is too late. I am standing between food and you.
And so I request SHAIBAL GUHA, you want to share something? No, nothing.
I would request Vijay to start off with the inauguration ceremony. Thank you, Anuj sir. Thanks for the wonderful talk, and thanks again. And thank you. I would request the audience to give him a standing ovation. Not only for the excellent talk, but for accepting our invitation to come over to Sitamarhi.
Really, we are fortunate enough that our national president has visited our state so many times, as sir has enumerated.
His contribution to Bihar is immense.
So please stay with us without wasting the time. Sir, please be seated, sir. Sir, for a moment, felicitation. So may I request our chairpersons to kindly felicitate our national president with, please stay with us. Please stay with us, sir. Please stay with us. Sir को बुलाइए. सर जो निकले होंगे. हाँ. Yes, sir. So now we have to conclude. After the inaugural function, we will conclude. So to start the inaugural function, may I invite chief guest of today's evening and National President RSSDI, Dr. ANUJ MAHESHWARI sir, over the dais, and I request Atul sir to kindly accompany our National President to the dais. Atul sir is our next chairman elect, sir. So now may I request our National Executive Committee member, Dr. B.K. Singh sir, and Dr. B.K. sir, and may I request Dr. Atul sir to kindly accompany B.K. sir over this. Sir, this way, sir. This way, sir. This is the ideal way, yes, sir. Thank you, sir. So may I now request the organizing chairperson, sir is not there, I think. So who will address, welcome address? Who is co-chairperson, sir? Suresh Babsinka, sir. May I now request Suresh Babsinka, sir, organizing chairperson of this conference, to kindly come over the dais. May I now request our chairman-elect, Dr. SHAIBAL GUHA, sir, to kindly, and Atul sir to kindly accompany. May I now request organizing secretary of this scientific program and diabetes update, Dr. S.C. Jha, sir, to kindly take your seat. Atul sir, to kindly accompany. May I now request our treasurer and next chairman-elect, Dr. Atul sir, to kindly come over the dais. So now, Madam, bouquet. So, may I now request Dr. S.C. Jha sir and Dr. B.K. Singh sir to kindly honor and regard our National President RSSDI with a bouquet and token of love and regard. Sir, all the dignitaries over the dais. Sol. And the culture of Mithila heritage, the Pag of Mithila. May I now request our National President and Chairman-elect and Organizing Secretary to honor and felicitate our National EC member, Dr. B.K. Singh, sir. Jha, sir. May I now request our National President, Chairman-elect and National EC member to felicitate our Organizing Secretary, Dr. S.C. Jha, sir. May I now request our dignitary to felicitate our Organizing Chairperson, Bhavsinka, sir, S.C. Jha, sir, Anuj sir, to felicitate Bhavsinka sir, organizing co-chairperson of this, organizing co-chairman. May I now request our dignitaries to felicitate our chairman-elect, sir, थोड़ा बीच में आ जाइए, सहवाल sir, to with now may I request our dignitary to felicitate our next chairman-elect, Atul sir, would be chairman-elect. Atul sir. Modi sir is there or not? Modi sir. Thank you. Thank you sir. मैडम हाँ 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 कर दीजिए कर सकते हैं, नीचे कर सकते हैं. हाँ 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 आइए. Now may I request sir, kindly felicitate our executive committee member Modi sir. आइए बीच में आ जाइए सर. Now, out of the box, may I now request our respected dignitaries to felicitate two of the stars for tomorrow's function. Two of the stars for tomorrow's community outreach program. May I request our respected dignitaries to felicitate Madam Sudha Jha and Dr. Kumkum. Jointly, please felicitate both of them because they are the co-star for tomorrow's diabetes community outreach program. Sir, please felicitate them. एक ही हो जाएगा, jointly solve नहीं है. और पाग है ना, दोनों पाग दीजिए. डॉक्टर कुमकुम कहाँ है वो अभी आ जाइए. Under their supervision, we have prepared the community outreach program, and they have worked day and night for arranging the program, for arranging the logistics. So a big round of applause for both of them. सुधीर सर, आप पहना उड़ा दीजिए मैडम. अच्छा ठीक, उनको दोनों लोगों को कर दीजिए, सॉल से दोनों लोगों को. हाँ. तालियां बजती रहे थोड़ा. They have worked day and night for the arrangement of tomorrow's community outreach program. And Madam ANUJ MAHESHWARI, sir, kindly felicitate Madam ANUJ MAHESHWARI. Madam. हाँ हाँ सर, मैडम अनुज महेश्वरी मतलब वही हो गई. अब अभी तो मत बोलिए सर. नहीं, पाग तो सुधा मैडम पहना सकती हैं, सॉल भी. हाँ हाँ. So a big round of applause for Madam Nisha Maheshwari. Thank you everyone. Please settle down. So now may I request all the dignitaries to come forward over the dais for lamp lighting and Saraswati Bandana. वहीं नीचे से कर लीजिए, वहीं रहने दीजिए. हाँ, नीचे से कर लीजिए. आ जाइए सब लोग कर लीजिए. वहीं रहने दीजिए सर, उसको वहीं रहने दीजिए, उसको वहीं रहने दीजिए.
Before we proceed for the lamp lighting, On behalf of all of us, I would like ANUJ sir to felicitate our Secretary, Dr. Vijay. Right. Thank you, sir. Now I would like all the dignitaries to light the lamp.
Now may I request our organizing co-chairman, Dr. Bhavsinka sir, to welcome the dignitaries by his welcome address. Bhavsinka sir.
On this auspicious day, I will like to welcome all our guest speakers coming from outside in spite of their busy schedule. Particularly, I will like to thank and welcome our national president who came here in the remote place in spite of busy schedules. I will also like the local delegates, madams and all friends who have registered for this, and in this marriage season they came here in spite of their engagements. I will thank the pharma people and welcome all to this. So they organized this event so nicely. Particularly Dr. S.C. Jha, this whole function was his brainchild, and he was planning since last 2-3 months with me and other friends. Thank you, and I welcome you all on behalf of API and RSDTI. Thank you.
Thank you, sir. Now, on behalf of RSSDI and as Secretary of RSSDI Bihar chapter, I would like to welcome you all for this wonderful CME, diabetes update, and the community outreach program tomorrow at Bajpatti. As we have mixed gathering of doctors of different specialities, I believe that every one of us are involved in care of people with diabetes, directly or indirectly. We are sometimes asked by our colleagues, neighbors and relatives about various aspects of diabetes, sometimes about medicines or sometimes about any complications or emergencies like hypoglycemia or coma, etc. Keeping in view of all these, we have crafted our scientific program, and I hope you have certainly enjoyed the scientific program. Let me also avail this opportunity in briefing few important aspects of our organization. Research Society for the Study of Diabetes in India, also known as RSSDI, is a large national organization with more than 13,000 members nationwide and several state chapters covering almost all states and union territories of our country. As the name denotes, it is not only involved in raising awareness to the primary care physicians in comprehensive diabetes care, but it also encourages its members in various research works in the field of diabetes. Regarding its membership, any MBBS doctor and above involved in diabetes care, directly or indirectly, can become the life member of this prestigious organization. they can become a life member by simple hassle-free online submission. There is no proposal seconder like that. Just online submission is required. So I invite all of you, those who are not the members of our organization, please come forward and become the member of this organization. It's a beautiful organization involved in research and scientific program. We have with us here our district coordinators, Dr. Rajiv and Dr. Samim. They will, of course, help you in membership drive. And it is a matter of pleasure for us that during this preparation of this CME, Dr. S.C. Hassan and Madam Sudha Jha has motivated, and around 15 members have been incorporated during this 15 days. So a big round of applause for both of them. I again express my heartfelt thanks to all of you for inviting us, and especially the learned speakers for accepting our invitation and joining us from different areas. I extend my sincere thanks and regards to our National President, who is very kind enough for Bihar. He has helped in so many ways. In last conference at Kochi, this is the contribution of our National President, that around 50 faculties were invited there at Kochi at different capacity, be it speaker or chairpersons. So this is first time from Rssdi Bihar we have been involved in so many ways. So I pay my heartfelt thanks to our National President for accepting our invitation and for blessing us on different occasions. Thank you all. Jai Jai Siya Ram. Long live Rssdi Bihar. Now may I invite our chapter chairman-elect, Dr. SHAIBAL GUHA sir, to address the gathering.
Good evening, everybody. As Dr. Vijay has rightly mentioned, RSDI is the largest organization of doctors interested in diabetes across the globe, I would say. And it is an organization with the sole target of research work in diabetes. And that's what it makes a difference. It's different from other organizations which are simple associations. And again, I urge everybody to become members of this organization so that we can do fruitful activity towards treatment and research of diabetes. And thanks to everybody, all the delegates who have attended, because it is actually the delegates who make a conference successful or unsuccessful. So thanks again on behalf of RSDI to all of you for attending this congregation on a busy evening when probably most of you are engaged or invited in some or other marriage ceremonies, and you have taken out time from that. Thanks to you all, and thanks to all the delegates, thanks to the dignitaries who are on the dais, thanks to our National President and Dr. ANUJ sir, and our National Executive Member Dr. B.K. Singh sir, who have come from far to attend this conference. Thanks again. Thank you.
Thank you, SHAIBAL sir. Now I have also to remind you that tomorrow we have community outreach program, and that community outreach program is the brainchild of our National President, Dr. ANUJ MAHESHWARI sir. And we have done the first state outreach program at Darbhanga. Now this is the second outreach program. So we will have the discussions tomorrow also. Now may I invite our National EC member, Zonal EC member, Dr. B.K. Singh sir, to address the gathering.
Thank you, Vijay. First of all, I like to congratulate Dr. S.C. Jha and Dr. Madam S.C. Jha. तो मैं चाहूँगा कि जोरदार तालियों के साथ इनका स्वागत कीजिए। इतनी तालियां थोड़ी कम लग रही है जितनी मेहनत डॉक्टर एस.सी. झा ने की है। सर्वप्रथम मैं माँ जानकी के चरणों में प्रणाम करता हूँ, इस धरती को प्रणाम करता हूँ, मिथिला को प्रणाम करता हूँ कि जहाँ पर कि माँ जानकी का स्वभाव बसता है और जहाँ के बारे में कहा जाता है कि मेहमान को सबसे ज़्यादा आदर दिया जाता है, और वो देख के हमें महसूस हो रहा है कि हम लोग मिथिला में सचमुच हैं। तो मिथिला वासियों के लिए एक बार जोरदार तालियां बजा दीजिए। अनुज महेश्वरी के बारे में एक बात कहना चाहूँगा कि दिलों में नक्श और जहाँ पे छाप छोड़ जाते हैं, दिलों पे नक्श और जहाँ पे छाप छोड़ जाते हैं, गुजरते हो तुम जहाँ से वहाँ अपनी पहचान छोड़ जाते हैं। तो डॉक्टर अनुज महेश्वरी जी, मैं आपका मिथिला की धरती पर स्वागत करता हूँ, अभिनंदन करता हूँ। और आपने जो महती काम लिया है, कम्युनिटी आउटरीच प्रोग्राम, कनेक्ट टू द पीपल, अगर आप प्रैक्टिस में पीपल से, जो मरीज हैं, जो कम्युनिटी है, उससे कनेक्ट नहीं होते हैं, तो आपकी पूरी की पूरी स्वास्थ्य सेवा अधूरी है। और इस काम में मैं इस बात की अभिनंदन करना चाहूँगा कि अनुज महेश्वरी जी ने ऐसा काम लिया और वहीं से सारी डाटा और सारी जो संभावनाएं हैं कि डायबिटीज़ क्यों बढ़ रही है इन स्पाइट ऑफ ऑल एफर्ट्स, इतनी सारी दवाइयाँ GLP-1, SGLT2, डिफरेंट दवाइयाँ आ गई, बट स्टिल द डायबिटीज़ इज ग्रोइंग लाइक एनीथिंग। 70 million to 100 millions and 100 millions to 150 millions, ये इंडिया का डाटा है। So where is the problem? कहाँ प्रॉब्लम है? एंड रिसर्च सोसाइटी ऑफ डायबिटीज ऑफ इंडिया, आपको मानना पड़ेगा कि देयर इज ओनली 2 सोसाइटी जिसकी वर्ल्ड में गाइडलाइंस पर को कोट किया जाता है, तो दैट इज वन RSSDI and second is the Lipid Association of India. That is the only 2 society. तो हम as an RSSDI, as a zonal member of this, first time बिहार में कोई जोनल मेंबर बन रहे हैं जो कि सेंट्रल में रिप्रेजेंट कर रहे हैं, तो मुझे सौभाग्य प्राप्त हुआ है कि आप लोगों ने मुझे उस वहाँ पर लैक पर भेजा है। कोई भी प्रॉब्लम अगर RSSDI से संबंधित है, एनी रिसर्च प्रोग्राम आप करना चाहते हैं, आपको डिफ़िकल्टी हो रही है, या किसी भी तरह का कोई आप कार्यक्रम शुरू करना चाहते हो डायबिटीज़ के पीपल को हेल्प करता है, जैसे कि डॉक्टर मोदी जी ने बहुत ही NCD प्रोग्राम स्टार्ट किया है पूर्णिया में, एंड वी आर गोइंग टू प्रेजेंट द दिस स्कूल गोइंग चिल्ड्रंस में जो NCD बढ़ रहे हैं, द ओबेसिटी बढ़ रहा है, उसके बारे में प्रोग्राम कर रहे हैं। तो सीतामढ़ी की धरती से मैं ये कहना चाहूँगा कि आप इस तरह के कोई भी प्रोग्राम, मैडम है गायनेकोलॉजी की इतनी बढ़िया पैनल डिस्कशन हुआ था, एंड एनी प्रॉब्लम विथ अदर जो भी ऑर्गेनाइजेशन के साथ मिलकर करना चाहते हैं और मैं उसमें एक माध्यम बन पाऊँ, तो मुझे अति प्रसन्नता होगी। इन्हीं सब शब्दों के साथ मैं RSSDI बिहार चैप्टर के लोगों का, डॉक्टर शैबाल गुहा है, डॉक्टर विजय है, डॉक्टर अतुल है, डॉक्टर RK मोदी, एंड यहाँ की लोकल कम्युनिटी, महावीर ठाकुर नहीं चले गए हैं, भवन सिंह का साहब, सबका बिहार चैप्टर की तरफ से, अपने पर्सनल की तरफ से अभिनंदन करता हूँ, नमस्कार करता हूँ। एक बार मेरे लिए भी जोरदार तालियां बजा दीजिए।
धन्यवाद BK सिंह सर आपके मधुर वचनों के लिए, और आपने हम लोग की हौसला अफजाई की। ऑफ कोर्स बिहार RSSDI थोड़ा रिसर्च में हम लोग का टारगेट पीछे है। हम लोग कोशिश करेंगे कि आने वाले समय में अनुज महेश्वरी सर के नेतृत्व में और उनके देखरेख में अच्छा से अच्छा रिसर्च प्रोजेक्ट करके हम लोग दिखाएं, और इसमें जो सारी कोई कठिनाइयाँ आएंगी तो उसको हम लोग अपने लेवल से ज़रूर सॉल्व करेंगे। ज़रूरत होगी तो अनुज महेश्वरी सर हैं वहाँ सेंटर में, और आप भी अब BK सर चले गए सेंटर में, तो हम लोग के लिए सुविधा होगी। अब मैं इनवाइट करता हूं अपने नेशनल प्रेसिडेंट RSSDI डॉक्टर अनुज महेश्वरी सर को कि वे आएँ और आशीर्वचन हमें दें।
थैंक यू विजय, थैंक यू बिहार चैप्टर, थैंक यू डॉक्टर BK सिंह फॉर द काइंड वर्ड्स, थैंक यू डॉक्टर SC झा एंड मैडम सुधा झा फॉर गिविंग द वंडरफुल हॉस्पिटैलिटी। So, as I already said that what the RSSDI should be and what the RSSDI is, the difference is still the same what is in our ancient saying, tamso ma jyotirgamay, asato ma sadgamay, mrityurcho ma to amritgamay, means मृत्यु से अमृत की तरफ। RSSDI को अब हमें इस डायरेक्शन में लेकर के चलना है. Lot of conferences has been done. Now the RSSDI conferences and hormonal imbalance in 3 phases of their life, like at the time of puberty, at the time of the pregnancy, and then at the time of the menopause. And after the menopause, the situation is absolutely different. Men don't have to face this kind of the fluctuation in their hormonal status. And that becomes the biggest reason for the cardiovascular mortality, because of nowadays scenario. It is not simply for the women to being in the house and running the house and keeping the household. Now the women is working in the offices, they are working as a physician, they are working as a obstetrician, gynecologist, and at the same time they are also looking after our houses. So they are doing the dual job, and with this stress of the dual job and with the stress of this hormonal imbalance, it is more important for RSSDI to work for women with the dual speed and dual capacity. So we are also looking for that. We are also, another important thing, this is time to involve more and more pediatrician to the RSSDI. Adolescent diabetes, adolescent obesity, as Dr. B.K. Singh said, and more of the type 1 diabetes, which is occurring mostly in the childhood, but very few of the pediatricians are taking. प्रॉब्लम है तो फिर एंडोक्राइनोलॉजिस्ट के पास जाने की ज़रूरत नहीं है, इंसुलिन तो और ट्रीटमेंट तो वो खुद भी दे सकता है. बट दिस थिंग, लेकिन ये बिहार चैप्टर का अपना खुद का डायनामिज्म है, खुद की. एवर हैड दिस थिंग इन माय माइंड दैट ए पर्सन हु इज ए प्रोफेसर एट AIM, they were really deserving, and the Bihar. So that's why I wish that these people should start working for all those things which I have just suggested. Community outreach, you are already leader, because you have already taken the next to Uttar Pradesh. You are, and Uttar Pradesh में शायद ज़्यादा इसलिए हो गए क्योंकि मैं वहाँ पहले से काम कर रहा था. अभी I expect that कि बिहार will cross the Uttar Pradesh very soon, as you did in the hypertension drive. And apart from that, lot of other things are there. Type 1 diabetes registry, we are looking for guidelines. Guidelines would be very soon be coming among you. We are working very hard with the help of Dr. B.K. Singh's guidelines. जल्दी से जल्दी आपके बीच में आए, अगर संभव हो तो रिसर्च रिट्रीट में रिलीज़ हो जाएं किसी तरीके से. इसी तरीके से हमारा उद्देश्य ये विलेज आउटरीच, कम्युनिटी आउटरीच में एक सॉलिड काम करके और उसके डाटा कलेक्ट करके और उसको हम चाहते हैं कि सबके साथ शेयर करें, सो दैट द पॉलिसी मेकर शुड ऑल्सो नो कि हमें अपने यहाँ के लोगों के लिए क्या गाइडलाइंस बनानी है, क्या पॉलिसीज़ बनानी है. यूपी में और बिहार में डायबिटीज़ का स्तर एक जैसा है, क्योंकि हमारा लोगों के लिए बना करके जहाँ पे ज़्यादा है डायबिटीज़ वहाँ पे हमें उनके लिए कुछ ज़्यादा एग्रेसिव स्क्रीनिंग करनी है, एग्रेसिव फ्रेंस के हिसाब से. पर उत्तर प्रदेश जितना डायबिटीज़ में, तो यहाँ पे हम प्री डायबिटीज.
सर हैं, बीके सिंह सर हैं, फिर हमारे करेंट चेयरमैन सुप्रियो सर, शैबाल सर, अतुल सर, और हमारी एक्सिक्यूटिव कमेटी टीम बहुत डायनेमिक है और हमें पूरी उम्मीद है कि हम सारे एक्सपेक्टेशंस पे खड़े उतरेंगे. कम्युनिटी आउटरीच में भी हम अच्छा करेंगे. और अब मैं बुलाना चाहूँगा इस आयोजन के आयोजन सचिव, पर मैं बता दूं कि पिछले 1 महीने से मैडम और सर से मैं लगातार फ़ोन पे रहता था और एक एक बारीकियों पर सर ने तैयारी की, एक एक बारीकियों को सर ने डिस्कस किया. ऑफ कोर्स फार्मा पार्टनर्स, दे आर द पिलर्स, दे आर द बैकबोन्स, एलेम्बिक एंड 3 डॉट. बट सर ने एक एक तैयारी की और सर और मैडम ने डिपार्टमेंट बांट लिया था कि भाई खाना वाला डिपार्टमेंट हमसे मत पूछना, मैडम से पूछना, ये वाला साइंटिफिक वाला हमसे पूछना. लेकिन हमारा इन्वॉल्वमेंट दोनों जगह होना पड़ता था. मैडम के साथ भी हमें डिस्कस करना पड़ता था, सर के साथ भी डिस्कस करना पड़ता था. तो सर और मैडम ने बहुत मेहनत से इस प्रोग्राम का आयोजन किया है, आज वाला प्रोग्राम भी.
और डॉक्टर सुधा झा की मेहनत का तो शुक्रगुजार रहूँगा, अभी जस्ट तुरंत उन्होंने किया. विजय के बाद लोग आते हैं, तो एक बहुत अच्छी बात कही उन्होंने जो हमको बहुत इम्प्रेसिव लगा, और इनके प्रयास से इनके मुख्य अतिथि के रूप में रहने के कारण 2 बड़े फंक्शन हमने रूरल आउटरीच प्रोग्राम कराए. मुझे गर्व है इस बात का कि उसमें हमारी कोर टीम दोनों में रही, ये है. और मुझे उम्मीद है कि विजय जैसे डायनेमिक सेक्रेटरी के रहते हुए, शैबाल जैसे डायनेमिक और एरोडाइट लीडर के होते हुए, बीके जैसे जोनल मेंबर को होते हुए, अतुल ही इज़ द साइलेंट वर्कर. he will never project himself, but let me tell you, he will put on the untiring effort and just slip away into the background. मैं उनका भी धन्यवाद बहुत करता हूँ। और इधर जो सबसे इम्पोर्टेंट है कि सीतामढ़ी जगह में जहाँ पर कि आज का लगन इतना तेज है और जैसे कि लोग आते रहे जाते रहे, फिर भी जो है हॉल वाज ऑलमोस्ट फुल। इसके लिए मैं सीतामढ़ी के सभी लोगों का बहुत बहुत धन्यवाद देता हूँ। गायनेकोलॉजिस्ट दे वर इन सच ए ग्रेट स्ट्रेंथ, जो फिजिशियंस हमारे थे ग्रेट स्ट्रेंथ। डॉक्टर M ठाकुर सर नहीं हैं, डॉक्टर B N झा सर जो है चले गए हैं, उन लोगों को शादी अटेंड करना था। डॉक्टर CV प्रसाद सर हैं, तो सब लोग जो है सो थे, डॉक्टर सीताराम सर, अंजू मैडम और सबको इंडिविजुअली तो सबका नाम ये समझिए कि सब लोग थे। अनुज जी के बारे में एक और बात मैं कहना चाहूँगा कि 2 उनका सर्कल यहाँ पर ये हुआ है। जैसे कि वो जब आए हैं तो अयोध्या सीतामढ़ी सर्कल भी कंप्लीट हो गया है। उनको मैंने जो है सो कल याद दिलाया कि भाई राम मंदिर जब बनाया था तो 55 गाड़ी यहाँ से गया था सब कुछ। तो सीतामढ़ी इज़ वेरी इंपॉर्टेंट। तो केवल अयोध्या के दर्शन करके आप जो है सो पूर्ण नहीं हो सकते। उन्होंने इस बात से एग्री किया, इसीलिए इस जगह साइंटिफिक टूर के अलावा उन्होंने इसको रिलीजियस टूर में भी कंबाइन करने के लिए अपनी सहधर्मिणी को भी साथ लाया। तो मैं डॉक्टर निशा महेश्वरी जी का भी बहुत बहुत धन्यवाद ज्ञापन करता हूँ। ऐसे भी कहा जाता है कि एक सफल व्यक्ति के पीछे में एक सफल महिला होती है। हैट्स ऑफ टू यू मैडम। तो और इसमें सबसे बात है कि डिफरेंट स्पेशलिटी के लोग, जैसे डॉक्टर जितेंद्र दत्ता है एनेस्थीसिया से, कोई गायनी से है, कोई दूसरे विभाग से है, सब लोग यहाँ पर हैं। और मैं जानता हूँ कि यदि आज लगन इतना नहीं होता तो इसका डबल जो है सो ये होता, जो अटेंडेंस होता हम लोगों का। लेकिन फिर भी इट वाज अ वेरी सेटिस्फाइंग एक्सपीरियंस। मैं सब लोगों का धन्यवाद देता हूँ। लास्ट बट नॉट द लिस्ट, आई वांट टू थैंक LMB पीपल लेड बाय none other than Vimlesh ji, his entire team, Karunakar, Shyam and others were there. Similarly, 3 Dot Life Sciences, Dravesh was not here, but his entire team, Mukesh ji and all, everybody was present there. Ashish for audiovisual presentation, it was excellent. He has been our scientific partner in most of the things. Hats off to you, Ashish. And I know your work is up to the highest national level. This program has been YouTube streaming also, and there is barcode for photographs which will share in the group also. और in hotel people जो इस समय में जो है ये एक तो अनबुक्ड रह गया था, पहले हम लोगों ने दूसरे भी किए थे लेकिन यहाँ पर रहा, तो ये उतने अच्छे स्टेट में नहीं था। तो होटल पीपल को भी मैं बहुत धन्यवाद देता हूँ कि उन्होंने पूरी मेहनत से इसको साफ़ सफाई करके इस योग्य बनाया जहाँ पर कि हम लोग साइंटिफिक डिस्कशन ढंग से कर सकें। थैंक यू ऑल, थैंक यू एवरीबॉडी, थैंक यू RSSDI, थैंक यू सीतामढ़ी, थैंक यू ऑल द डॉक्टर्स ऑफ सीतामढ़ी. Be one. We are the one of the most academic units in the country, and we will remain to be so. And inspired by all this organization, we will continue to do. Will further promote the research as Vijay has suggested. And today we have got a very favorable team which will promote the research also. Thank you so much. Thank you everybody.
Thank you, sir, for your nice words to each and every aspect of the organization. Again, on behalf of Rssdi Bihar, I thank you all, our national president with his madam, all the guests, all the doctors of Sitamarhi, all the organizers, all our pharma partners, Alembic and 3 Dot, hotel people, and all those on behalf of Rssdi Bihar. I again thank you all. Now, before we disperse with national anthem or before we proceed to dinner, let us gather for a group photograph. अच्छा ठीक है प्लीज कैरी ऑन. नेशनल एंथम.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल उत्कलवङ्गा विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Now group photograph and then we will proceed for dinner. Ajay, CB sir, आइए CB sir, आइए मोदी सर, आइए मोदी सर, आइए इधर आइए मोदी सर, आइए सर, सीताराम सर ऊपर आइए, आइए सर, प्लीज प्लीज आइए, मैडम लोग आप लोग भी आइए, मैडम बीके सिंह सर, मैडम अतुल सर, मैडम मोदी सर, मैडम अनुज महेश्वरी, सुधा मैडम कहाँ गई? सुधा मैडम